Welcome to HIMSS Day 2. We're having a blockbuster time here. For those of you who are not with us, I'm sorry, you're missing so much, but that's okay because we're bringing it to you live. That's why we're doing HIMSS TV this year. It's our first time, 55 years of a conference, and we're finally doing television, and that's so that the world can be here. We're happy you're with us. We've got an amazing series of interviews today, and rather than try to run you through a little taste of that, I'm just going to get started right away with a gentleman by the name of Dr. Nick van der Heijden. People call him Dr. Nick on social media. That's your handle. I guess they can't pronounce van der Heijden, but that's all right. We figured it out. You've been tweeting out a ton of stuff, getting the word out to, again, all the folks who can't be here but want to be here. What are you telling them?
So I think one of the things that we achieve with social media is to spread that word, much as you're doing with HIMSS TV. From the perspective of an individual, I look at it through the eyes of a clinician in particular. And I try and focus on the trends and what's happening here that's new, exciting, and would be interesting to people that are either not here, or even for some of the folks that are here.
Yeah, right.
That potentially may not see it. This is a big conference.
Oh my God, I mean, I keep feeling like I'm trying to take a sip from a fire hose. There's so much coming at me and I just can't possibly, get it all. So how do you make sense of it? I mean, how do you divvy up your day? You can't possibly go to everything you want to attend.
So I always start out with a plan, but I accept that that plan is going to change.
As soon as it starts, right?
And it does. It changes dramatically. I try and take the opportunities that arise. If you set up meetings, they sometimes don't occur. I go with the flow. And social media helps that because sometimes I can find out about things before they occur or as they're occurring, and I can participate in them.
Right.
And even if I don't participate, guess what? I can go back and look at the feed and review some of the activities of the things that I missed. So it gives me a double dip into the content.
All right, so themes, let's talk about them. And what I keep hearing, and I want your take, from we've gone from just collecting data to now analyzing it, artificial intelligence, but even predictive analytics. Talk about that process.
So I think we've crossed the divide of not having data, although at this point whether the data is truly clean,
scrubbed,
is still a question.
Trustworthy.
Had a fascinating conversation yesterday, one of the tweet ups where we talked about cleansing the data, and one of the points that I made that seemed to resonate with folks was, why should we impose that burden on individuals, in particular clinicians?
Right.
We don't ask the head of JP Morgan to enter stock prices.
Right.
Why do we ask clinicians to enter blood pressures and content?
Well, I mean, now you're opening a whole can of worms. I mean, that's one of the issues. I spoke yesterday with James Madeira, head of the, CEO of the AMA. He told me that on average, doctors spend an hour with patients and 2 hours processing that. I mean, that's crazy. It's inefficient.
It's madly inefficient, the use of that high quality, well-trained resource. So one of the thoughts around some of the AI machine learning capabilities that I was suggesting was, can we use some of that technology to clean up the data?
Right.
And, we heard from Eric Schmidt in his opening keynote.
Yep.
He talked
former
about
CEO of Google here at HIMSS.
That maybe we could have something listening in. We've talked about that certainly at some of the companies I've worked out in the past, the natural language processing. Very tough to do, but it would be a big win with the clinical community because now suddenly instead of focusing on the technology, I'm focusing on you, the patient. That's a win-win all around, right?
Probably the way it started off way back when, and somehow we've kind of gotten it away. HMOs in the 80s and 90s, managed care, and now we're finally getting back to the patient first and enhancing that relationship between patients and providers. You're a strategic advisor. I've only got about another 90 seconds with you. You've got a unique approach. Why don't you tell people how you do it?
So I set up a company called Incremental Healthcare. I focus on the small incremental improvements that we can learn from other industries and indeed from healthcare that essentially add up to this big revolution we know we need in healthcare, but have to find, but cannot jump to that eureka moment. Uber was not this one moment in time where we go, wow, this is brilliant.
Series
I know
of
we
steps.
can bring those small improvements, and the beauty of that is it's lower risk, because if you make a mistake, it's easy to correct, it costs you less, and it gives you an opportunity to feel successful.
Yeah, right.
And the one pathway to rapid success is to enable people to feel successful and companies to feel successful. I help people find those small improvements.
I like it. And if people want to find you, how do they do it?
So I'm at Dr. Nick1 on Twitter and incrementalhealthcare.com. Both of those are good destinations, although pretty much you can find me in every social media platform at this point.
All right, Dr. Nick, thank you. We'll let you get back to work and spreading the gospel.
Always a pleasure. Thank you very much.
Oh, thank you. All right, as we've been saying, so much happening here at HIMSS. Revolutionary approaches, and that's exactly what we're seeing from our next guest. He is Perry Price, CEO of Revation Systems. Perry, thanks for being with us today.
Great to be here today. Thank you.
All right, you just heard from Dr. Nick on his approach, where it's incremental. It's one step at a time. Enhanced medication services. Tell us what that approach means.
That's a new customer of ours, recently acquired. They do medication therapy management for their parent company, RX30. And they're all about connecting medical payers with regional and community pharmacies.
You know what's interesting? That's one of the other themes. I know I'm talking about themes today, but I think it's important here on day 2 because we want to help put this in perspective for people. But breaking down walls, breaking down barriers, some of the ACOs now that are reaching across state lines, even Midwest and Southeast coming together. What has enabled that to occur?
So it's a variety of things. One is big data, obviously.
Right.
So payers are a great source for data, and then communication systems that can bridge the data to a real-time action. Right? How do we connect this data with what happens next? In the world of MTM, or medication therapy management, it's all about how do you take that data and then offset some cost in the future. It might be 7-10 years down the road.
Wow, that's a long payout.
It could be a long payout, right? But you're trying to offset a very big event through medical adherence, and that's a complex transaction.
In other words, a hospital would rather perform 200 colonoscopies than treat one colon cancer.
Correct, yeah. That's a great way of looking at it.
Yeah. I wish I could claim that, but it was actually a hospital director who planted that seed in my mind yesterday. And that's what I love about being here, all the conversations and just broadening my mind. What are some of the conversations you've had over the past 24 hours?
Well, with EMS and others, it's, in this world of communications, high trust certified solutions operating in this new cloud era that we live in is increasingly important to a variety of customers. So as applications move beyond the boundaries of the hospital, where we've typically been pretty slow providers in the provider space, to get to the cloud, a new sense of focus on security and really dealing with digital transformation, how we handle multimedia, inbound, outbound communications, and really connect it with that big data that enables us to be far more efficient and offset all kinds of costs for the industry as a whole.
How would you characterize the level or degree of trust for patients?
Right. For patients, it's number one in their minds. There's so much of it out there. Right now, today it's assumed there's going to be a breach event of some type.
I know, and that's really what I'm getting at. I'm glad you said it, not me.
It's the unfortunate world that we live in. So, security is an ongoing effort daily, right? And it has to be built into an organization from the ground up. One of the things that we do uniquely for our customers is we focus on security from day one. And we also go with the more advanced options on a variety of things. So in the world of high trust, there's multiple options.
So give me examples.
There's a CMS extension to the high trust process, and if you go with the CMS extension, it's pretty robust. The other extension is versus an island of solutions, where you might have a high trust offering in a cloud as part of a company that didn't start with a security offering.
Right.
Our company, we started with security in mind. So it's actually the entire company. So high trust is about process, it's about security, it's all of our products, all of our services, all of our employees. It's all encompassing.
So put it in a context that my grandmother with diabetes can understand.
So for your grandmother with diabetes, using a large payer, and we can name a few, there's she can rest assured tonight that when communication systems like ours are being used by companies like EMS, their data is protected, it's safe, it's secure.
What about the trend now of, I guess 10 years ago we would have called it outpatient services. Now we just call it getting out of the hospital and going home as soon as you can, and telemedicine, et cetera. How do you make that secure?
Well, we see that's the future of everything. Right?
Really?
It's kind of bridging what happens in the clinic, what happens in the ER, what happens in the home, right? And so that there's universally a new system And I always like to use Adobe as an example. You know, Adobe created
Adobe software?
Adobe software. They
Really?
created this document called a PDF.
Yeah,
right?
tell me about it. I send them all day long.
But when you communicate with your bank,
right,
you communicate on their portal. When you communicate with your hospital, you communicate on their portal. When you communicate with your medical specialist, you communicate via their portal. We think there's an opportunity to make that communication multimedia, universally acceptable by patients, just like an Adobe Acrobat Reader, to use an old analogy, but really in this world of multimedia communications to deliver care in addition to just communicate about care.
Yeah, so it's not just the messaging, but it's how you deliver the message.
That's correct, yeah.
Would I be remiss to say that trust may be one of the 2 or 3 biggest themes of this entire conference?
Trust certainly is. I'd say it's a big theme here. Trust, simplicity, consumer engagement, right? And what's happening in behalf of the consumers as it relates to all those things.
Yeah, sure is. Brian Price, thank you.
You're welcome.
Thank you for being here.
Great to see you today. Thanks,
I learned so much in all these conversations, and they just keep happening. We're joined now by Chris Logan. He is the Senior Healthcare Strategist at VMware. And you know what I love about this conference, Chris, is the fact that I will speak with a doctor at one moment, I'll speak with someone from the American Medical Association another, and then I get to speak with you, a tech guy.
Yes, I am a tech guy.
And you're all aligned. And by the way, a former Marine I see on your lapel pin.
Yes.
I have to talk about that just for a moment.
Sure.
You were in the Marine Corps for how long?
8 years.
8 years.
8 years.
And
all technology roles.
Really?
But I finalized my career as an information assurance officer. So very focused on protecting data at very sensitive levels across, entire government systems, right?
Yes, boy, I'll say.
Translates very well into healthcare.
It certainly does. I'd be remiss if I didn't say thank you for your service, first of all.
You're very welcome.
So tell us about how you made that transition from the Marine Corps to VMware.
So I had a longer journey in between there. So I actually spent my previous 10 years before VMware as a healthcare CISO. So I served on the provider side, providing security programs, building security programs to protect patient data and really align security to be a business enabler for healthcare delivery. Prior to that, I spent some time in banking and some time in higher education. Oh yeah, so I've seen a lot of different verticals, all focused on security and really protecting data and understanding how security can enable the business at the end of the day.
All right, why do breaches keep happening?
From a VMware perspective and what I see across the industry, cybersecurity in general, we've always had this concept of chasing bad. Right? So if you think about security technologies that are out there today, they're really not proactive, they're reactive. So when you chase bad, we know the bad things are already going to happen. Now we can only limit so much of the impact of what that bad's going to be. From a VMware perspective, we're really starting to look to turn that upside down. Instead of chasing bad and trying to find the needle in the haystack, we're enforcing good to minimize the haystack so we know what the needle is.
I'm interrupting you, but
no, please go ahead.
I was flying in from New York City. The security line at JFK was like nothing I have ever seen. I don't know how long I was in it, 45 minutes, an hour, almost missed my flight. And I thought about what you just said, finding a needle in a haystack and how absurd it is that we're all taking off our belts and our shoes, etc. Is that a fair analogy?
So it's a fantastic analogy, and I'll akin it to TSA pre-check, right? So you go through a process to understand who the person is that's traveling. You vetted them through a process, good or bad. At the end of the day, you vetted them through a process. So you know they're a known good entity.
Yes.
So at VMware, what we're focused on is really looking at the application or the individual or the network now, understanding, excuse me, how it works. How it works, right?
Yep.
Knowing what the intended state of the application is, how it's supposed to operate, and monitoring and only allowing that to take place.
So when something is supposed to happen that doesn't,
it's variation.
Yes.
Right? So when we look for variation, and when we're looking for known good, variation stands out like a sore thumb.
In other words, if a credit card charge goes through in Hong Kong with my number and I live in New York, that's sort of out of the ordinary.
It's a red flag, right? And I think the financial institutions have done a really good job around detecting fraud because they're incentivized to detect fraud, right? So they know geographically that swipe took place somewhere where you're not.
Yeah, right.
Right? They have that intelligence. We're building that intelligence into the platform from the architecture level up so that we know what's supposed to be happening. And when something's not happening the way that it should, we act on it immediately.
Okay. You're a programmer, I'm not. So I'm a little out of my element, but try to help me understand conceptually when you talk about changing the architecture. What does that mean in layman's terms?
So it's really digging in at the ground level. So I'm going to take it like you're building a house, right?
Please.
You don't install windows before you put walls in.
Right.
So most organizations will apply security controls after a foundation has already been laid down. So we've installed the application, now we're going to layer security on top of it.
On top of it, right.
We want to layer security in right at the foundation and make
it,
it, just paramount to how this thing's supposed to run. So it's secure by design. It's better that way. We're not actually bolting on from the back end, we're applying it right up front.
And how many layers typically?
Many layers, because if you think about how operating systems work or how networks work, we're in the network layer, we're in the application layer, we're in the device layer, but now we're also taking a good stance at looking at it from the individual, so the identity as well. So is that user actually doing what they're supposed to do? Do they have access to what they should have access to? And that talks across all those different layers to have a really calculated response to minimizing the threat landscape.
Yeah, right. Artificial intelligence, again, and cybersecurity, we're talking about that. Artificial intelligence, huge. Everyone's talking about it. What's VM's approach?
So I think the industry as a whole is still really defining what artificial intelligence is.
It's new.
Right, it's new. So some folks will say, well, it's precision medicine, it's all these other aspects. From a VMware perspective, artificial intelligence really lies back down in the technology platform, right? So if you think about what we do for the industry as a whole, we're building this thing from the foundation up. What we want to get to a point is that there's enough intelligence in the platform itself so that you don't have to have human interaction when something goes wrong. So going back to that finding the needle in the haystack. So if I know my platform that's running my EMR isn't acting the way that it's supposed to with the baseline, automation and that intelligence just takes place and actually remediates any of those findings. So we're kind of coining this our self-healing network, our self-healing healthcare network, right?
I like that.
So we're taking the human out of it, the human element out of it, and letting the machine learn and adapt to those changes that take place.
Wow, cool stuff. You've got a huge crew here. I know you need to get back to them. I'm going to come find you right over there, 50 feet away in the hall later. Chris,
Absolutely.
Thank you.
A pleasure talking to you. Take
likewise. Care. Thank you. All right. In our nation's service as a Marine and now making healthcare better. That's pretty amazing. And we're joined by another gentleman here, Gurpreet Singh, partner of U.S. Health Services. He's the sector leader at PwC. Thank you for being here.
Thanks.
So,
Thanks for having me.
Right, amazing. You just heard that conversation. It's fascinating to hear all the different components, from the doctors to the programmers and to you as a consultant. What's the biggest complaint or concern that you hear from the people who are asking for your advice?
So the healthcare landscape is changing very rapidly. A lot of exciting things that you see, right? You see in the press just in the last month or so some big combinations of some very, very well-renowned companies like an Amazon, Berkshire, JP Morgan Chase coming together, like an Aetna and CVS coming together, unlikely combinations.
Assuming the Department of Justice will let it happen, right?
Correct, exactly. And so you see these unlikely combinations happening.
Right.
And so a lot of our clients are thinking, well, is my strategy that currently is status quo, which typically for a lot of providers is, I want to grow to get bigger, right? I may want to standardize care, I may want to regionalize my care, in other words, grow around my region and get larger sort of points of access, or I may want to virtualize care. And those kind of are the main strategies for many providers. They see a lot of these deals happening, and they say, well, maybe I should adjust my approach to how I grow.
Which is reactionary as opposed to getting ahead of it, as we just heard from Chris.
Right.
You just used the word virtual.
Yeah.
And I guess that would be telemedicine, among other things. It's sort of a catch-all. What does virtual mean to you, virtual medicine?
So virtual is everything from creating a new environment for patients to actually be more like consumers, right? So when you think about what you do during the day, you're not thinking all the time about your healthcare.
No, hopefully I'm not thinking about it at all.
Exactly, and that's the whole point. And so the idea is, in the healthcare industry, we need to be thinking more like a journey, right? The journey of the consumer. Right. And today, hopefully you don't actually have any healthcare issues and you don't have to worry about it.
Right.
But the day that you do, and the day that you start investigating what those issues are and who you should talk to and what doctor you should schedule around, and maybe you don't actually have to go in there physically. But there's an opportunity potentially for you to actually get some virtual care. And so where we see a lot of the market moving towards is what we would call do-it-yourself healthcare.
So how does that work? Give me an example.
So, for example, like we have a lot of advances in the wearable technology, right? We have a lot of advances in diagnostics that are remote care. And so a lot of that information is sitting on our bodies. And so there's an opportunity
blood pressure.
Pulse, blood pressure, even what we're seeing in the diagnostics and therapeutics area, like A1C levels, glucose, right? Insulin levels. And so what we're seeing in a lot of chronic care settings, where you actually have, when you want to keep a patient well, so to speak, there's a lot of information that's being created by mobile medical applications, class 2 medical devices that have to be FDA approved, that a physician will have to prescribe for you. I'm going to prescribe an app for you and the insulin that treats you.
Well, okay, now you're getting at one of the companies that I follow, called iRhythm, that IPO'd about 1.5 years ago. They create that little Zeo patch to help diagnose arrhythmia. You'd wear it for 2 weeks. Well, they just got an FDA approval now for continuous monitoring. That's
CGM.
the that's the sort of thing you're talking about.
Exactly. So that amount of data that's coming out from me as a patient, or as a consumer rather, is now available. Now, we still have to work on the privacy issues, and we have to work on the accessibility and the interoperability, but that's creating a different type of view of me as a consumer. One of the things that we just launched a paper around is this concept called a digital twin.
Tell me more.
So digital twin essentially is replicating you as a human being, but putting all of the aspects of your genetic makeup, the inputs and outputs, and putting that into a computer in silico. And so, for example, let's say you eat a hamburger for lunch today, and you decide, well, I'm going to have a Coke as well. And based on the makeup that you have, what the response might be to your body 5 years from now.
How cool.
5 years from now.
So you could model out all kinds of scenarios.
Exactly. When might you get diabetes, or maybe you don't. Maybe you actually have insulin resistance, in which case...
Create the app.
Yeah.
I mean, literally, could I do this?
Hyperbolic discounting. It's basically what it is like, it's the decisions that you make today, that may actually affect you in the future.
Love it.
So that's the value proposition. Now the key point is how do you move the healthcare constituents and landscape from treating the sick to actually providing service to the well? Because ultimately what we're talking about here in this digital twin concept is being able to force the wellness conversation.
Sure.
Right? And wellness today, aside from value-based care, which is moving in that direction, doesn't have a true business case. Right? Until you and I as consumers take responsibility for our care. Right? And employers that we work for potentially have an opportunity to manage that risk if their employees are more well.
So you have to make it obvious for people. What's the old, it's like a Chinese proverb or something. Tell me and I'll forget, tell me again and I'll remember, show me and I'll understand.
Right, exactly.
And you're showing people.
Absolutely. Yeah, you have to show what the response might be if you make some decisions.
All right, so how do you make this commercial? How do you put it in my hands?
So what we're seeing a lot of is there's two major areas of potential investment and where we think it could move.
Right.
And I mentioned the unlikely combination of JP Morgan, Berkshire, and Amazon. Now that play is basically a large set of employers, right? So the three employers together account for about 1 million covered lives. Okay, and so that 1 million covered lives still is a rather small fraction, but it's a robust number. So we see employers taking a pretty big role in managing and helping their employees with the wellness, and there's a value proposition for that. Absolutely, right? If you can manage that denominator, and you can manage the risk across that denominator, you actually can lower your costs. So there's a business case right there.
Sure.
The other side is where we see, in diabetes, typically you have underinsured or uninsured patients, right, and consumers. And so one of the things that we're seeing a lot of activity around is focusing on communities, right? So for example, we did some work with the University of Texas in Brownsville, Texas, which has a large epidemic of diabetes. And typically you have...
It's all that queso they eat.
Exactly, but it's also having the right coaching and the right understanding, and so you have to surround the consumer with not just the pharmaceutical company that provides insulin, or the provider that sits in Texas, or the retail clinic. You need to have all of those, including the community, surrounding the consumer, that allows you to make nudges and adjustments and create some education. Wow. And I think that's actually pretty fulfilling, because you can actually change the curve.
Change behavior. I mean, that's the holy grail.
Absolutely.
Gurpreet, thank you.
Thank you. Appreciate the time.
All right. What a pleasure. All right. Susan Kressley is a founder and owner of Kressley Pediatrics. And Susan, it's a pleasure to have you here.
Thank you for having me.
What has brought you to HIMSS 18?
Well, I think that traditionally there's not been a lot of pediatric focus at the conference, and if you look at the demographics we serve as pediatricians, kids and adolescents, they do everything digitally on their phone. It's like their sixth sense, and so we think that our population is ripe for innovation. But I think that there's some unique constraints to what we have currently in electronic health records for adolescents and children, and some of that is around privacy, which is why I was presenting yesterday on the topic, and it was a really robust and engaging conversation.
Yeah, my intuition and I'm thinking about my nieces and nephews. I don't have children of my own, but they're the group you're talking about, 6 to 16. They don't think about privacy the same way I do. They're much less private, and they're okay with that.
Yeah, they really are, and I think that we've been using a lot of HIPAA and as an excuse to not serve them well. And we talked yesterday about patient portals and having access, and the kids all want to contact me by FaceTime or text me directly on their phone. They don't want to have to call up the office and make an appointment. They want it easy, they want it quick, and they want it in a way that already is with them in their pocket, in their phone. And so I think that we're really ripe for innovation, and we need to get out of our way, but there's more than technology. This is a technology and a processes and an institutional framework. A lot of places,
a mindset, in other words.
There are a lot of institutions and organizations that have decided that they can't protect granular information about adolescents, and so they turn portals off, for example, at 13. I heard yesterday from someone who was a mom of a complex child who had access to all these resources and specialist information on the portal, and one day it all went dark.
Why?
She wasn't sure. She was sure if it was because the child confided something into one of her providers, and so they had to shut down the whole portal, or whether it was because she turned 13 that day and she really lost access to care that was critical for her. But I don't think it's just an adolescent issue, which is why we talked about this in a broader way yesterday. I don't know if you have aging parents.
I do, as do we all.
But if you were responsible or a healthcare proxy for your aging parents, or even your spouse, you're an emergency HIPAA contact, do I have the authority to see nuanced pieces of my mother's healthcare record that maybe she wanted to keep private from me?
Well, that would only be if I were her official caretaker, and by that I mean legal.
But there are actually HIPAA rules where you can see access to portal. You can say, as a healthcare proxy, help me navigate it, because there's a long interval between I can't take care of my own health, but I need my more astute adult child to help me guide that. And I think along the way there has to be a way to protect granular pieces of information. And I don't think this just applies to the adolescent population, but we should figure this out so that we have everybody's privacy protected on a granular level when they want it to be, but not freeze people out who are trying to actually affect care.
I think what you're really getting at is who owns the data, and if I'm hearing you correctly, it's the person, the patient.
Not only do they own it, I think that it should be a shared chart, and the person who's entering the data, whether it's a patient sharing their uploaded blue button information with me or whatever, they should be able to say, here's what you have, but I only want these kinds of people to see it. I don't want your billing staff to see that information, I only want the provider to see that information. Or I only want my primary care doctor to see what I've confided about.
Wait, and you're saying we should or should not go down that selective
I think
route?
we should. I think we need to make it granular enough, and so that people can decide there may be small pieces of their medical record that they want to keep private or among a small cohort of their caregiver team, but not shut down the whole thing when there's one piece of sensitive information in there.
And would there be ways to code that? So if it's an emotional issue that you want to have kept secret, you've been treated, you might have been put in an institution to address some issues that you had, and that was for 2 months, and you don't really want people to know about that. So could it be coded in a certain way that it's both private and you sort of know that it's not necessarily, your heart that's at risk?
I think so. We just don't have the standards.
Kind of thin ice.
No. I think it's a pond we should start skating on. We may sink, but I think we should start skating on it. I think that we should come up with some way of deciding, and there are some standards in the 2015 certification about creating pieces of the CDA that can be held private, but they're optional, and I think that it's not granular enough. I don't want to hide the whole med list. I just want to hide the fact that my adolescent patient asked me for Plan B, and they don't want their mother to know about it, right? So I think we should go skating on that pond and figure out how we can look at really small, discrete packets of data and protect them the way the patient wants them protected, but share them with their most trusted and appropriate caregivers.
Obviously, this is a national issue. Is it one that should happen in a public governmental stage, or an industry stage, or more sort of at the healthcare provider stage?
So I think that the standards have to be set, and I'm always about private-public partnership, because then you have buy-in from the beginning and someone's not telling you what to do. But I think that the decisions about which pieces of that should be kept private have to happen. This is called health care because we care for people.
Good point.
And so I think that it has to be done at that caring conversational level, and it should be directed. And if someone says to me, I want to keep this private, it's my obligation to say to them, here's the implications of not sharing this with everyone, so that we can make a shared decision that's really best for their health.
All right, Susan, thank you.
Thank you so much.
What a wonderful perspective.
Terrific.
All right. As you just heard from Susan, it's really a lot about partnership. And that brings us to something I want to share with you that we heard yesterday. I was able to sit down with Ashley Rodrigue of Lenovo and Casey Sutton of Intel. Again, partnership. You might not have thought these two companies would come together, but they have. And here's what they're doing.
So the vPro brand is really this umbrella that gives IT professionals this peace of mind when they buy that brand. And what it means is there's all sorts of different features and functionality within that vPro brand that deliver real value. So for example, you would have the ability to remotely activate, manage, secure, and keep track of these devices at the edge using active management technology from Intel. So this is really great for reducing operational costs and creating efficiencies for those IT professionals. And they're using these platforms that are already using today. So they're very familiar with how to use them and the tools that are used to remotely manage these devices. Furthermore, within that umbrella, you sort of get this, long roadmap, 15 to 18 months of stability with our stable image platform. So what this does is it really gives the IT professionals this frame of mind and ability to know that when they buy that vPro brand, they have all of those things under that umbrella.
And then from a Lenovo hardware perspective, I think one of the beautiful things is we're able to offer that manageability with vPro processors and the whole gamut of our ThinkPad, ThinkCenter, and ThinkStation lineup. But we're bringing that kind of technology in a way that's really meaningful and helpful in that healthcare setting, right? The right types of technology in the right places really can streamline a workflow. They can help promote a good and meaningful patient interaction. And at the heart and soul of it, it can make sure that you have quick, easy access to the critical information you need. So when you look at something like our tiny desktop and tiny in one monitor, there's a time and a place, whether that's at a nurse's station or maybe that's at check-in or maybe it's actually at the patient bedside, where this kind of device really can be a game changer. And having that combined with vPro technology really is what makes it an excellent solution in the healthcare space.
So Remote Secure Erase is a really great feature that's available on Lenovo self-encrypting drives that allows you to remotely secure and erase an entire hard drive if you should realize that that PC has come into the wrong hands or potentially is lost. So this gives the IT professionals a lot of control to remotely manage and take care of any sort of security issue before it arises.
When it comes to Lenovo, because we have so many amazing devices that feature those vPro capabilities that give you, the options to consider things like remote secure erase and manageability, it really goes a long way. And so we really like to embrace everything that Intel brings to the table with their products and with vPro especially. But then we always like to take it a bit further. And sometimes it's with security solutions that are a little bit more simple but really powerful, like our actual ThinkShutter this year that's a little privacy slide over your camera, and some of them are a little bit more advanced, like taking technologies like Windows Hello and pairing it with our match-on-chip fingerprint readers, or even our glance technology that helps you take locking down infrared camera login and sign out to the next level. So it's really our philosophy is to embrace and extend and make sure that we're offering as secure and manageable solution as possible.
So one of the great things that we've done this year in the vPro platform is that we're actually delivering fantastic performance. We're talking our very first 15-watt quad-core processor, which is up to 31% more efficient than 7th gen Core. This is phenomenal, and when it comes to being able to put that into different form factors and really sort of take advantage of that performance as an end user, you really notice the difference.
Yeah. And let me tell you what that means for the Lenovo Health lineup this year. When you look at our ThinkPad lineup, for example, you've now got all of the power and performance of quad-core processing, but in ultra portable form factors, like even something like our X1 tablet. This is a 1.9-pound tablet that now features quad-core processing capabilities. This is the kind of device, this or even one of our Yoga convertible 2-in-1 devices, that really allow you to bring patient engagement to the next level and really talk about incredible ways to work with our patients and to work with and collaborate with our own other clinicians in the workspace today. So I think that's a really powerful story when you think about bringing all of that power and performance to really incredible form factors with the ThinkPad lineup. Now, I think that's about all we have time for today. So thank you guys for taking the time to listen. And if you want to find out more, don't be shy. Come on down and see us at the Lenovo booth 2443, and you can always find out more from us and also our friends at Intel by checking out our website, www.lenovo.com/health.
One of the highlights now here at HIMSS 18, we have the opportunity to share with you a conversation I had with Dr. James Madeira. He's the CEO of the American Medical Association. He's the man at the top of the heap. He's thoughtful, he's moving forward, and I so enjoyed our conversation. Here's what he told us.
Heart disease. You too, unnecessary ER visits. And hey, unmanaged depression. Don't get too comfortable. We're talking to you, cost inefficiencies and data without insights. And fragmented care. Stop getting in the way of patient recovery. And pay attention. Every single one of you is on our list. At Optum, we're partnering across the health system to tackle its biggest challenges. Optum, how well gets done.
CEO of the American Medical Association, joins us now. And as Dr. James Madeira, CEO of the American Medical Association, joins us now. And as you know, the AMA is at the intersection of healthcare and technology as it carries out its mission to improve the health of the nation. Dr. Madeira, CEO of the AMA, obviously has been a leading voice discussing the physician. James Madeira, CEO of the American Medical Association. All right, thanks for bearing with us. We had a couple of technical issues. Don't worry. No, they had to. All right, thanks for bearing with us. Like healthcare, everything's a work in progress, and we had a couple of technical issues here with the TV switchers. We'll get them fixed. Don't worry, and we'll bring you that interview with the CEO of the AMA, Dr. Richard Madeira. But in the meantime, joining us is Dr. Richard. Actually, can I call you a doctor?
You absolutely can.
Dr. Richard Loomis, Chief Informatics Officer for Elsevier. So pleasure to have you here.
Thanks for inviting me.
Okay, I'm going to be honest. You almost seem too young to be both a doctor and a chief informatics officer. How'd you make the switch?
Yeah, so I caught the informatics bug in medical school and residency, actually,
really?
Recognizing the tremendous opportunity for healthcare information technology and informatics to help improve healthcare. And since then, have really focused on that as a cornerstone of my
You know,
career.
it used to be. I come from an investment background. CIO was chief investment officer. Then it became chief information. Now we've got informatics. Why did we need to create informatics versus information?
Yeah, informatics is a field that bridges medicine and healthcare as well as technology, and so
which is really what HIMSS is all about.
Which is exactly what HIMSS is all about. And so my role and my team's role within Elsevier is actually to serve as a bridge between the domain of healthcare and the delivery of healthcare and the technology to build industry-leading healthcare IT solutions.
So I always like to talk examples, right? Because then you can make it real for someone. So what's a project you're working on right now that really excites you, gets you out of bed in the morning?
We're really excited about clinical pathways. So to date, clinical decision support, or helping physicians and members of the care team make better decisions based upon data that already exists within the EHR, as well as best clinical practices, have been fairly simplistic. Where we're headed is actually creating longitudinal clinical pathways across the care continuum to help
breaking
providers
down silos.
Exactly, help providers and members of the care team deliver better care, reduce the unwarranted variability of care, and ultimately improve outcomes. We recently announced the acquisition of Via Oncology, which is a leading clinical pathways company, and they're focused on standardizing and improving care in oncology, and we're really excited to continue to grow from there into other specialties and disease areas.
Do you ever get resistance? People say, no, wait, you don't understand. This is my kitchen, and I own this, and I don't want you in here.
So yes, we do get some resistance, but it's education and it's analytics around actually presenting the data around existing care patterns, existing inefficiencies, and how we can help them, both healthcare organizations as well as providers, ultimately deliver better care. And the data speaks for itself.
Yeah, right. Is this an approach you think that is sort of best put to practice in, say, general practice, or in specialties, or if someone has massive trauma where you have to coordinate a bunch of different specialists?
Actually, all of the above.
Really?
And
I knew you were going to say.
For us, the question is where to start. So, in the example of primary care, using pathways and advanced clinical decision support to help primary care providers, for example, better take care of patients that have congestive heart failure, and perhaps deliver care that would be at a level consistent with an actual cardiologist. And so, again, across all of the various domains, including allied health professions and nursing, providing decision tools to improve care.
One of the things that I think about a lot is how much more I use my phone now than I ever did, and I feel like it's exploded in the past year. I just got the iPhone 10. Is it possible that my phone is going to be my gateway to my doctors over the next several years?
Absolutely, and it's already happening. We're already starting to see that. One of the areas that we're focused on is delivering and harmonizing the same clinical decision support that we're delivering to members of the care team to patients, and delivering patient education and engagement information via mobile, as well as decision support to help patients make better decisions.
Yeah, again, examples. I love examples. How do we do that on my phone?
So it's multiple modalities. In the same way that you interact with any app, you have reminders, you have text messages, you have apps. Same sort of approach.
Yeah, I remember the first time I got a text from a doctor. I was seeing a dermatologist. I had some sunspots. They were worried, and he said, just snap a picture and send it to me. And I did, and I thought, wow, that's amazing. And he texted right back, okay, looks good. Send me another one next week. I mean, I was like, wow. There are no walls here. This is my doc. I always thought of my doctor as up there, and now he's down here.
We're really starting to see a shift in the way that care is delivered, and in large part actually, is due to the transition to fee for value as opposed to fee for service, and enabling physicians to deliver more efficient care through technology, which is a theme that we're seeing at HIMSS this year.
Yeah, absolutely, very powerful theme. Dr. Richard Loomis of I want to say informatics, but it's actually Elsevier. You are the Chief Informatics Officer at Elsevier. Thank you.
Yes, thank you.
Great perspective. All right, as promised, we figured out our equipment in the back, and I want you to really put down your pencil or stop typing on your cell phone. Just give us 5 minutes and lend your ear to our interview yesterday with Dr. Jim Madeira. He's the CEO of the American Medical Association. I was really touched by some of the things he had to say and where he is taking the AMA. Here you go. Dr. James Madeira, CEO of the American Medical Association, joins us now. And as you know, the AMA is at the intersection of healthcare and technology as it carries out its mission to improve the health of the nation. Dr. Madeira, CEO of the AMA, obviously has been a leading voice discussing the physician perspective on the need for technology that works for physicians at improving care for patients. He's here at HIMSS discussing challenges with current technology, including the electronic health records that are contributing to increased burnout among our nation's physicians. But he's also hopeful that we can change that. He's hopeful about the future. Doctor, I'm so glad you're with us. Dr. Madeira, it's an honor.
Happy to be here.
All right. So the AMA, such a massive organization, so important to the health of America. And as I understand it, you really have, you see it as 3 different arcs. Can you talk to us about what those arcs are and what their impact is?
So we've traditionally spent time convening and in advocacy. We continue to do that. But our 3 strategic arcs that are related to the mission are professional development, creating the physician of the future, starting with medical schools, structuring medical schools for that future state. We will then move on to graduate education. So the first arc is professional development. The second is chronic disease. 80% of our healthcare spend in this country is chronic disease, and we've moved in the last half century from not only acute disease to chronic disease, and yet we're structured more for the acute phase. We have to restructure and think about how we take care of this chronic disease that's going to increase in burden year over year. And then the third strategic art is allowing professional satisfaction by providing tools and resources around physicians and patients to have them interact, spend more time together, and have that flow of data be more effective.
I mean, that's really what it's all about, isn't it? It's about doctors being doctors and putting patients first, and yet somehow it's all gotten so complicated that they end up having to, become data scientists somehow in the process.
That's exactly right. I mean, we did a time motion study showing that physicians currently, for every hour they spend with patients, which is the hour that patients and physicians find most satisfying, they spend 2 hours, 2 times as much time in administrative burden and data entry. And that's driving physician burnout as well.
Yeah, of course it is. How do we deal with that?
So one thing is we give better tools, better data flow. We have projects both in Chicago and an innovation studio in Silicon Valley that deal with better flow of data, better organization of data, so you don't have to pick and choose and look around records, that you have a data object rather than 70 data elements. And then also a system that allows data to flow in a liquid way, in a secured, blockchain secured, permission-based way as a utility, like every other multi-sided market has a utility, like the financial industry or the power grid. We need that utility for rapid, secure, permission-based, inexpensive clinical healthcare flow.
I can't believe you just said blockchain. I mean, there it is, the most unpredictable new technology out there, and you, the head of the AMA, are potentially embracing it.
Absolutely, and we just spun out a company from our innovation studio, Akiri, which is a blockchain secured information transport framework.
So the AMA actually is in Silicon Valley investing and doing what we usually think venture capitalists do.
Yeah, and I think what we add to this is there has to be sort of a physician intuition in the problem definition that we start around the patient, rather than having, there was a shirt, when I was at University of Chicago, there was a shirt that was sold in the bookstore that said, that's all well and good in practice, and in the back it said, how does it look in theory?
Right.
And we have started a lot of healthcare tools and resources in a theoretical way without defining the problem around the patient. And we think that where the patient exists is the truth of our healthcare system. That's where we have to pay attention.
Do you think we got away from that somehow in the 80s, 90s, when suddenly HMOs became these massive organizations and people got lost?
I think in part that was true. I think another part of that is physicians historically have paid attention exclusively to their knitting. They've been heads down in their practices, heads down with patients, and yet it's 20% of our economy. It's a major source of important work and consideration for employers, and we have to really have that voice be part of the problem solving, be part of entrepreneurship in America.
Well, I have to tell you, I've been so impressed at the eloquence of the various C-suite executives here at HIMSS who are formerly doctors. I mean, arguably, you're one of them, right? You were a pathologist and GI specialist, and took the tract of trying to make a difference in a larger way.
Yeah, I had this came to me. I was at a health economics program at Stanford, a small group of us for a couple of days, and the person beside me said, he wishes there wouldn't be enough positions in healthcare for physicians that were graduating. I said, what are you talking about? He said, well, if you look at all other professional degrees, they're equally diffused throughout our industrial ecosystem, except for physicians that are all focused on patient care, and yet that's such an important part of our economy. It would be nice to have that voice expressed elsewhere as well.
Right.
Yeah.
Do you think, you mentioned 20%, and that's a ballpark number, I'm sure you can take it out to several decimals. healthcare, roughly 20% of U.S. GDP. That's a lot higher than a lot of the other countries of Europe, certainly. Is it too high?
It's probably too high. In fact, we probably spend $3 trillion on a $2 trillion problem. And
so it's 50% too high.
It's probably about a third too high. And when you look at that, there's a lot of administrative churn, administrative cost. Some of that is data has to be reproduced because it can't flow from place to place. Some of it is we take this physician workforce and we only effectively utilize a third of it. And the other 2/3, we say, why don't you be a data entry clerk?
Right. Which is where we began, right?
Which is where
the doctor spends an hour with a patient and 1 to 2 hours putting data into a computer.
And information flow. If I'm a patient at University of Chicago and I have a long, complicated medical history, and at 2 o'clock in the morning I'm in an accident and I show up at Northwestern, it's as though I never existed in any physician's office before.
Right.
There's not good data liquidity.
So do we need a set of national standards? Do we need to let the big data companies, Google, IBM, on and on, Amazon, I shudder to say, help us figure it out? I mean, what's the path forward that lets doctors be doctors and get back to tending for patients?
If you look at our work in Chicago and also in Silicon Valley, what you'll see is we engage all asset classes of the health system. So consumer technology, corporate technology, all of these different classes have to be engaged because it can't, our problem is being siloed, and we can't approach a solution in a siloed way.
Right. Yeah, that's certainly one of the themes. We could go on, and I'm sure everyone here would like to hear more of you. Dr. Madeira, thank you.
Thanks, Adam.
All right.
Listen up, heart disease. You too, unnecessary ER visits. And hey, unmanaged depression. Don't get too comfortable. We're talking to you, cost inefficiencies and data without insights. And fragmented care. Stop getting in the way of patient recovery. And pay attention. Every single one of you is on our list. At Optum, we're partnering across the health system to tackle its biggest challenges. Optum, how well gets done.
How do you approach now in your role as Chief Medical Officer at Optum what you want to go after? How do you prioritize the different diseases and issues?
Yes, it's a great question. We try to go after the things that have the most impact. And so it might be the problems that affect the most number of people, the problems that are most expensive, or the problems that result in the most misery in some ways. So we really try to shoot for those targets, we swing for the fences, and that environment that we're at allows that kind of innovation. Sometimes we succeed, sometimes we don't, but at least we're trying to go after the stuff that matters.
Yeah, right. What are the top priorities for 2018?
So we have spent a lot of time on the opioid crisis. It's now the leading cause of death in young people. It came on so suddenly. We think that that means that perhaps we have reason to be optimistic that whatever it was that made it come on, perhaps we can reverse engineer that and actually lead to some improvements.
How do you go about doing that?
So it's almost the same as how do we treat a complicated problem like cancer. The first thing you do is a diagnostic scan. You do an MRI, CAT scan, you find the tumor, and then you test it. You say, well, what are the treatments that are going to affect it? Then you go back and scan again. It's the same with the opioid crisis. We created a framework. So we looked at, are we prescribing too much? Are we actually then helping people avoid chronic use? If they become dependent on opioids, are we helping them the same way? And then we intervene, we change benefit design, we make sure they have access to the right medicines, and then we run the analytics again. We repeat that cycle over and over, and hopefully at the end of that, we've helped our members feel better.
And what's the message of big data with regards to little data? Collecting data on lots of people who suffer from opioid crisis and then dealing with the one.
Well, I think the issue is that when you just have one person in front of you, you're not exactly sure what's going to happen to them.
Right.
If they're on a certain dose of medication, if they actually have a certain type of exposure, they live in a certain environment, they have a certain kind of insurance, you just don't know because you have a small sample size. Big data, all it does, it gives us statistics. Just like, you know, if you're going to flip a coin, you know, if you flip it 100 times, about half time of your heads, half time of your tails, it's exactly the same way. We want to look at those patterns and then use that intelligence to come back and help that person make the right decision.
As much as we know about the opioid crisis, why would any doctor today prescribe an opioid?
Well, opioids are effective for pain, and used correctly, they are terrific in many ways. However, the issue is that they're not always used correctly. And part of the problem is that physicians and others have developed habits, some on their own and some that have been imposed on them, potentially by pharmaceutical marketing practices and other strategies that have led them to learn the wrong ways to prescribe and take care of these patients. Patients also, to some extent, are expecting a medicine that might work immediately without thinking about the long-term effects. So I think we're trying to assume positive intent. Doctors trying to do the right thing, patients want to do the right thing. Our information, the research we're doing, hopefully will help them make those better decisions.
So obviously the opioid crisis, one of the pillars that you're trying to knock down. What's another?
So another key area we've been working on is Alzheimer's disease. Again, affects lots and lots of people, tremendous human cost, and research is still in its infancy, to be honest, to help us understand how to both prevent Alzheimer's disease and then treat it as it moves on as well.
And how does OptumIQ as a platform enable you to do that?
Yeah, so OptumIQ at its most basic form is exactly what we talked about. It's taking the data, putting it in a form that makes sense, analyzing it, and then using insights to drive better health in some way. So with Alzheimer's disease, that's exactly how we start. We have lots and lots of data, tens of millions of medical records. We try to create healthcare intelligence. So we've created an artificial intelligence model. We're using a deep learning model to see if we can predict who's going to develop Alzheimer's disease. And then we take that information and then we work with our partners, perhaps pharmaceutical companies, so they can identify people that are at higher risk, or maybe our care managers so they can reach out to these patients, help them actually prepare for these problems they may develop over time. So it's that sort of three-part structure, and we hope that in Alzheimer's disease, opioids, and in potentially dozens of other areas, that same strategy can be effective.
So obviously the key to data is data collection, which means patients have to participate. They have to be willing. How are we nationally on the mindset of getting people to take responsibility and actually collect data or do stuff that collects data for them?
I think we're at a point where almost all patients realize that having their information available both to themselves and to their physicians and potentially other researchers to help others, that is a sale that's been made, so to speak.
So we're there.
Most people
That's the
feel
good
that
news.
way. Yeah. I think people want to donate their data. They want to have access to it. They want to own it. That's not the hard part. The hard part now is actually creating the technology that actually makes that a reality.
And where are we on that scale?
Yeah. So we're still making progress there. I think that
means we're early.
Yeah, we are early. You know, I think anybody who's tried to get their medical records from the hospital could probably understand that we've still got a little
Just trying
ways
to get
go.
X-rays impossible.
Yeah. But I think it's better now than it was 2 years ago. And I think that 2 years from now it's going to be better than it is now. So part of it is, can we accelerate that transition? I'm optimistic.
Do we need a sort of nationalized standard or code to facilitate that? Or is that sort of happening almost like blockchain in the background? It just kind of happens.
That's a good question. I mean, I think that just as the internet really exploded when there was a standard to some extent, so everybody knew that there were some basic things that had been agreed upon. I think healthcare information is very similar in that way. Those standards exist. The extent to which that they need to be expanded still remains to be told.
Yeah, it certainly does. We could go on and on and on. Doctor, thank you for being with us today on
It's a pleasure to talk to you. Thank you.
Likewise. One of the reasons I enjoy coming to HIMSS is that I get a chance to meet so many different people, and if we're lucky, we actually get to bring them together simultaneously, and that's what we're actually doing exactly right now. David Harlow is principal of the Harlow Group, LLC. It's healthcare and law consulting, and of course we're joined as well by Nick Vanterheiden, whom you've already met. He kicked us off today as founder and CEO of Incremental Healthcare. Nick, Dr. Nick, thanks for coming back.
Thanks
David,
for having me.
You as well, since we actually spoke yesterday.
Yes.
And what I wanted to do was bring together two people who I really enjoyed speaking with earlier and say, you know what, we're going to have some fun and talk about security, because my theory here is that we have someone who is in favor of, shall we say, maybe a little less security or a willingness to knock down silos. Dr. Nick, I'm thinking that's you. And David, wearing your lawyerly hat, that you might be more in favor of more security. Is that a fair?
Fair enough.
I think that's absolutely right. The challenge for anybody that's sitting in a clinical setting where you're faced with hundreds of patients, lots of things to do, anything that prevents productivity is a hindrance, and security has a tendency to make it difficult to practice clinical medicine.
Because we erect walls, we say, no, this is my data, that's not your data, this is my patient, not yours, you don't have access.
Absolutely.
David?
Sure. Well, I work with care providers and tool makers and tool builders as well, many of whom are resistant to the notion of security. But as I like to say, you know, the law is the law, the rules are the rules, and there's certainly the ability to do what needs to be done within a framework of security. And I help people build that framework and stay out of trouble.
Yeah, right. What are the protocols from your point of view when you're trying to establish those guidelines?
Well, when I'm coming into a project, I need to understand what is the use of the data involved, who has access to the data, and what are they doing with it, who are they sharing it with, in what format is it coming in what format and through what channels is it going out. And we need to secure those channels in an appropriate way. And really the biggest risk factor in any healthcare security situation is the human factor, human factors. We are all a mess of risks, and we need to lock those down in appropriate ways.
In other words, we need structures that protect us from ourselves.
Absolutely.
I mean, it sounds reasonable, Nick.
Yeah, but what he's essentially talking about when he says human factors is, of course, the clinician. So that puts us in the frame as a fault if we make a mistake, which inevitably we do. I mean, I think the reality of human beings is we make mistakes. And the challenge I have with that sort of perspective, whilst I absolutely agree in, you know, the confidentiality of information and the desire to sort of secure it appropriately, is ultimately, what does the patient want? They want the best possible care. And if I don't have the information because I didn't know I needed it, so this concept of need to know and those issues, that creates a barrier that is a hindrance to the overall practical delivery of the best possible care for that patient. And that's a challenge for a clinician.
All right, so how do you honor certain confidentialities and yet make it accessible? I mean, where's the common ground?
So I think one of the things that I would say around this is that I wish we could go back 40, 50 years when, you know, there was just this level of trust that, you know, if I needed the information, I would access it.
Well, now you're taking me back to not Wall Street. You're taking me back to Main Street, right? Wall Street.
Oh my God,
no.
not Wall Street.
A lot of trust.
No, but like, you know, I feel like I'm on the Andy Griffith show, right? Where, hi, Opie. Hey, go see the doc. What can we do for you, Opie? You know, it's...
So I think we need to sort of parse this a little more finely.
Please.
There's a question of security and there's a question of privacy. I 100% agree with the proposition that a patient could say, I don't care about the privacy of my data. I want to make sure that my data goes from here to there securely, so that people can help me, but it has to be securely. Right. So I'm willing to sign away my privacy rights within an overall secure framework.
Yeah, and perhaps the common ground here is a level of trust that says, I as a physician am going to honor that and access information. Unfortunately, it just takes one bad actor, and we've seen plenty of them, who accesses inappropriately information for all sorts of reasons. And the sad thing is it impacts everybody. If we could find some middle ground that allowed the physicians who are doing the best possible thing that they can, and allow them that full access within the boundaries, and deal with the inappropriate access as a separate issue so that we don't lump everybody together, that would be, for me, a better sort of path forward.
Right. Yeah, I like actually divvying it up into privacy versus security, because they are different issues.
Right, they are. Now, one battalion of the security police from the federal government has issued a draft trust framework around health data security, and that's out for public comment right now. So it'll be very interesting to see where we go with this in sort of a post-meaningful use world, and trying to reach a new collective understanding of security and a trust framework for health data.
So as soon as you said that, immediately the hair went up on my back, thinking, wait a minute, this isn't the government's role. This should be private industry, and yet the government is the largest payer in the country, isn't it? What, about 60%? If you add up Medicare, Medicaid, government employees in effect.
Possibly more?
Yeah, possibly more. Stay tuned. So government maybe should have the biggest voice, or be one of the arbiters as we try to navigate. What's the draft resolution look like now?
Well, so the challenge is to build a workable understanding and agreement with the enforcement abilities of the federal government behind it, but with input from industry, with input from patients, with input from providers, because everyone needs to be on the same page in this respect.
How willingness do you two, and Dr. Nick, jump in here first, how willing do you think players at all levels would be to separate the privacy versus security issue and treat them separately, related but separate?
I think there's an absolute willingness to do that. The challenge is, how do you do that effectively and in the day-to-day practice? I can't think about it in those terms. I think about it in pure, what is the best possible outcome for my patient and how do I achieve that? And I don't know that I think necessarily as rigorously as you know, appropriately my colleague does here, who says, no, these are separate issues. And I understand that, but I don't know that it falls down all the way to the clinical work phase. So the challenge is the implementation. I don't disagree with the principle, and doing it in a way that doesn't erect barriers of time in particular, that allows me to follow the protocols and be aligned, but without hindering my capacity to deliver the most effective care quickly to my patients.
All right, is it possible, and I'm going way out of the box on this one, that blockchain might actually provide a framework for how we might do this? In other words, blockchain is totally out there in the public realm, all right? So you don't have the privacy concern. There is no privacy, but all the data is encrypted, so unless you are one of the two counterparties, you cannot see it, right? I mean,
yeah, so
again, I'm out of left field here.
I'm a big fan when it comes to this of blockchain. I thought the seminal paper by Eric Topol and Leonard Kish that talked about the sort of essentially patient control of data using a blockchain principle. The challenge that I believe exists with blockchain is our capacity to understand how we would achieve that and do so in a timely and effective manner. So I think we're a little ways away, but I'm very hopeful that there's an opportunity there.
Yeah, it's moving at light speed. It's hard to understand.
No, I think the operative word in your question is might. You know,
yeah,
I mean,
all right, no, that's fair.
We might get there.
I said I was in left field.
That's okay. I think we might get there. I think it's early days for blockchain. I don't think we're ready to rely on blockchain. I think the smart contracts that are an integral part of the blockchain universe are open to interpretation. And if we have a transaction that is cemented into the blockchain, we can't have a smart contract that is open to interpretation, because the whole idea is that it's black or white.
Sure.
So I don't think we're there yet.
Do you think anyone else is talking about this here at HIMSS the way we are right now? It's why I actually brought the two of you together, sort of the pro and the con.
I think the most interesting conversations are the ones where we can have discourse that is civil, something that tends to be lacking in a lot of instances, sadly. I mean, truly, I love to disagree with people. In fact, one of the things that I love is an opportunity to take a counterpoint that I maybe don't believe in. It helps me understand it.
Yeah, right.
Sure. I wish we saw. So I think we do. I've seen it certainly in some of the tweet ups. As a social media ambassador, we were doing that yesterday. We'll be doing it today. I think more of that is absolutely part of that imperative, with respect.
Yeah, right.
Right, absolutely. I think we need to bridge the gap between the tools that people are building around security and otherwise, and the implementation. And again, to me, it all comes back to the human factors.
And that's true, it is. It's all about the human beings, but if we could just accept that we're infallible and not apportion blame like the airline industry did, the way that they reached Six Sigma in terms of lack of errors was, instead of focusing on pilot error and what they failed to do, understand the reason for the error and fix the error, not the people.
Absolutely.
Yeah, I like it. Dr. Nick, thank you. And David, thank you, especially for coming back to let me put the two of you together side by side.
Always a pleasure. Thank you.
All right, lots of great conversations happening here at HIMSS, and we're so thrilled to bring so many of them to you. Not all of you can be with us. There are 47,000 of us here, but for those of you who aren't, well, that's why we're here at HIMSS TV. Bob Whiter is Director of Product Management at DirecTV, and you might ask yourself, what in the world is DirecTV doing at HIMSS? Here you go. Bob, DirecTV has 9 people here at HIMSS. What's DirecTV doing at HIMSS?
We're really just here to show that, you know, entertainment as part of the AT&T footprint, you know, of a company is a valuable resource when you walk into healthcare facilities. It touches every single person that actually walks through the door of a facility.
In other words, I walk into my doctor's office and there is a TV there that has an opportunity to present unique programming to me.
Correct. And typically when you walk into a lobby, the TV's on mute.
Right.
Right? So you're really focusing on magazines. So we want to really start to educate that there's ways and technology to really deliver content to your guests or your patients in, you know, a waiting lobby area, to an overnight stay, to a pediatric appointment. There's ways to deliver content to everybody that walks through your door, even though that their content needs may be extremely different from millennials to Gen X to Gen Y to 80-year-old people going to hospital.
So you're actually creating very specific healthcare-focused content that's geared at a specific doctor. You walk into a dermatologist, it's going to be different healthcare-type content on that TV than, say, in an emergency room.
It can be. What we're really focusing on is just the delivery of content, right? So there's a lot of challenges in this industry today about how to deliver content to a TV, or as we all know that people are consuming more and more content on their personal devices every single day.
Right.
It's how do I get content to that screen, or the big screen on the TV, or people in, say, dialysis clinics are looking at models where they're actually giving equipment for people who walk in to lease or to use while they're in the facility. So our goal is to provide a well-rounded content portfolio, but to really distribute content in ways that could be used by my phone, my tablet, the TV, to a leased tablet or phone that walks through. That's really the goal of DirecTV.
This is a whole new business.
It's a new business because DirecTV is typically used as just, we're a content company, but our idea right now is to really push content. It shouldn't matter what screen it goes onto. It's just delivering the right amount of content, or what the content that people are expecting. Today, we expect to watch all of our content on their phones, or a certain generation of us.
Sure.
But older people going in expect to have a remote control in their hands, watching, you know, old reruns on TV land.
So help me understand the business behind this, because obviously DirecTV is a business. You're selling ads against some of this content. Is the content sponsored? Maybe a combination of the two? How does that work?
It's a little bit of both. Our content, we secure all that through the traditional programmers out there. You know, we have the ability to do ad insertion, but we work with a lot of people at this show are, say, what we call service integrators, that we provide content to them and they custom build solutions for specific markets. And what we're here at the show to really emphasize is that we're here to extend our content to a variety of different technologies. Again, we're really a content provider where we can do some solutions, but we're not a solution integrator. We're going to walk into a hospital and integrate emergency medical records and all these other things.
Right.
But there are system integrators at these shows that we can partner with and work with to deliver our content in an experience specific to a vertical or a sub-vertical within
Okay,
healthcare.
so now I'm going to push you. Give me an example of a contact you would like to meet at this show and the type of transaction you would like to put together.
Yeah, it's really anybody who's doing patient engagement systems. So really focusing on the entertainment experience where you have a single pane of glass, albeit a TV set or your phone, where they're delivering, say, emergency medical records or electronic medical records, or patient training, you know, about my surgery, or what do I need to be, you know, looking at when I leave the operation room. And then content plays into that overall service. We're one piece of a solution, so any of those people here that are doing solution integration where content is one part of it, those are absolutely the people that we're here to meet to really focus on.
You know, one of the reasons that we decided to run with HIMSS TV this year, which is a first, was that there's so many people who couldn't actually get here to HIMSS, and yet they want the content. And it's sort of it's a little bit in reverse. People are actually there, they're captivated, and then you want to give them even more.
And that's what we do see in healthcare. I mean, we know that we're looking at different studies where how does content, and that entertainment experience impact your overall status or the way that you view a hospital visit. And believe it or not, it comes out pretty high in terms of what it is. I mean, we've all been there, unfortunately, in some form or another,
Yeah,
but
right.
it's depressing sometimes when you go in and sit down and you're in a bed and you have a pillow speaker and you have a TV that's 20 feet away from you and the experience just isn't there. So you look to resort to my own personal device, is how do I watch content on my personal device? Well, then that starts to impact a whole other area that is focused on here is just what the infrastructure is of these facilities to handle content, which is now being brought over the internet, such as YouTube or Hulu or Netflix or DirecTV Nows are big over the top. That starts to impact this organization or this vertical as well. It's just not traditional TV. It's also now infrastructure and broadband that starts to impact how do I deliver content.
Okay, so now I'm going to get geeky on you. If I've got all kinds of monitoring devices next to my bed, does that interfere with the signal? So is that part of what you're talking about? The infrastructure?
It shouldn't, because everybody in a hotel today, even doctors and nurses, have access to their Wi-Fi on their personal phones. And so what we look at is the ability to say, how do I get my content over the Wi-Fi network to people's personal devices in a secured manner, or a manner that doesn't impact the broadband side? Because it's happening today. We know that you go into a hospital or healthcare facility and people are watching Netflix on their device. Well, that ultimately is running off your Wi-Fi network, which is impacting your broadband network, which unfortunately is used for other healthcare needs. And so that's what we're here to really talk about, AT&T proper, but also with DirecTV, is really to deliver content in a way that fits the actual customer. If it's to a TV set, we absolutely do that. If it's to a mobile device, we can do that. If it's certain types of content that they want to deliver, we can do that as well. It's just really to kind of a coming out party a little bit for DirecTV to really say, hey, we're here to help push content to make the experiences of all patients and all verticals, sub-verticals of healthcare, it's a need that we want to address.
Well, guess what? It's a coming out party for HIMSS TV as well. So,
excellent.
Bob, congratulations, and thanks for celebrating with us.
All right. Thank you very much.
All right. All right. Welcome back. We have a very special conversation happening right now on HIMSS TV. Amanda Green, a patient advocate, healthcare activist, and the owner, author, etc. of lupuslady.net. An amazing person. I'm excited for you to meet Amanda. And Max Stroud, you may remember her from yesterday. She and I had a chance to speak. She's senior staff at Galen Healthcare. And what a great opportunity to speak with both of you. And you're actually hosting a panel later today. And it's about bringing patients and doctors together in a very intimate sort of way. Amanda, why don't you kick it off and tell us a little bit about your story and how you decided to team up with Max?
Well, it all started at HIMSS. Last year at HIMSS, when Max presented with her sister, it was a patient story at HIMSS, which I, as a patient advocate, I felt was very important.
Right.
And I was like, I want to tell my story, and Max knows how to bring it out. So,
yes,
hi Max.
She does. She's good at that.
Hi Max, I'm Amanda, LA Lupus Lady. Also, lalupuslady.net. Didn't mean to correct you.
Oh, please. No, we want it right. Say it again so we get it.
lalupuslady.net.
Got it.
But basically, LA Lupus Lady on Twitter. I tweet too much. You can find me there.
Okay, I do too. Are you on Twitter, Max?
I am.
Good. Yep, that's where we come together. Okay, so you went to Max and said, I want to tell my story. I want to let this be an example to others.
Yeah, and the patient experience isn't told enough at HIMSS. It's all about patient engagement and patient experience, but they don't have that many.
Not that many patients.
They're doing better, but they're including patients this year, and I'm so happy that I can tell my story and share my journey, and Max has helped me figure out how to tell my story to make it relevant to the audience, because they don't want to hear my entire story, but
sure.
How healthcare has helped me and impacted my healthcare. It truly has.
Improve your living proof. You've been living with lupus for 35 years?
35 years. Oh, yeah.
And here you are.
And here I am at HIMSS, and I'm sharing my patient experience, and I'm just a representative. I'm one person.
Right.
but many patients have similar experiences. And even in our session today, we include a lot of people, and the social community of patients is pretty big. So we went out to them, we reached out to them, they're included in our conversation. And you know, it's important that data work for us, that it doesn't just work for the providers and the insurance, that it works for the patient.
So Max, this is really your specialty, using the tools of social media and communication and getting the word out. How do you go about that in Amanda's case?
Well, I think that there's really some simple questions that you could ask any patient group, any focus group. If you were really looking at patients as consumers, you know, tell me about your healthcare story. What are your goals for your healthcare? Not just I want to get better or I want cancer treatment, but like, what are your life goals and how does healthcare fit into that? And then what are the tools that you use today? What are the technological tools you use today to access your healthcare? And then where does technology get in the way? And those simple questions can really, that's what we use to bring out Amanda's story. And it's something that's recreatable. It's kind of a qualitative way to look at, you know, what's happening in the healthcare system and where are we really missing the mark? We're throwing tools and apps at patients all the time, but where is it helpful and where is it just too much and turning people off?
Now, in fairness, is that because this is all kind of new, you know, using apps? I mean, the iPhone was only created 10 years ago, so that people are excited and they're just seeing what works, or are we not doing it in a thoughtful enough way?
I think it's a little bit of a combination, but I think part of it is not doing it in a thoughtful enough way, and that as healthcare organizations or insurance payers, we tend to think of things as what's happening within my healthcare system. And so we build the tools for the people within those four walls. And our patients don't exist like that.
Yeah, right.
Our patients see providers in multiple healthcare systems. Our patients go on vacation and HIMSS and might need to get some medical care. You know, patients really need something that travels with them through time and information that follows along with them, as opposed to like, well, this is my chart in Epic over at this hospital, and this is my chart in Allscripts in this hospital, and I have these two different portals, but then I find social media really helpful for connecting with other patients and learning about my disease state.
Yeah, that's way too much for someone to have to deal with. I mean, how do you deal with this, Amanda?
Well, I was gonna say, come to my session, session later today.
And find out.
But well, I go from, and during the appointment with my providers,
right.
I'm the patient, and then I become the health records manager. So as the patient, you know, they might tell me, avoid stress, you've been feeling a little fatigued, get some, avoid stress, get some rest, relax. But as the health records manager, I have two different, my rheumatologist and internist don't practice at the same institution. So as soon as I leave those doors, I become a health records manager.
Even though you're the patient?
Even though I'm the patient.
And do you want to be the manager, or do you not want to be the manager?
Well, right now I am, and I'm going to do it until there is a single EMR.
Entity.
I mean, not like our soundbite, but my soundbite kind of that I've been saying is, I have one social security number. I have one driver's license. I can't have, it's 28.
One patient ID? Yeah, right.
Yeah,
makes sense.
Not just one patient ID, but one complete medical record that if I have lab work at one institution, why can't, when I go see my doctor at the other institution, have the results of that lab work 2 weeks later?
Okay, I'm glad you've just said this. I came out of Wall Street, all right? And on Wall Street, you have what's called a prime broker, so that even if you have an account at Morgan Stanley and JP Morgan and Goldman Sachs, the prime broker brings it all together and says, here's what you own, and here's what you've done. And that's what you're talking about. Be my prime broker.
I'll be.
Right?
I am my prime broker.
Yeah, so you want someone else to do it, so you can be the patient.
I'll
just get better.
I'll start a prime brokerage. I need to find a way to cover patient expenses.
That's part of the thing too, right? Is that when you're sick or you're dealing with a new diagnosis, you have a whole life adjustment, right? So you need time as a patient to heal.
Right.
You need time to recover. You need time to work with your family and attend to social relationships. You need time to, make healthy meals.
Yeah,
and so all the work that we ask
patients to do. Like, you need to go to this other office in the hospital basement and get paper copies of your record to carry them somewhere else. Or you need to get online and take a screenshot of this and email it to this other doctor. That's time that takes away from their healing and taking care of themselves.
Yes, you're absolutely right. Max, Amanda, thank you. It's eye-opening. Tell us when your session is going to be later today.
Yep, it's 1 o'clock.
1 o'clock.
Palazzo K.
Palazzo K.
It's a really big room. Bring all your friends. We want to see it packed. It's not going to be your typical hymn session. We're going to basically talk about how Lady Gaga and Health IT come together for this patient's journey.
I love it. Oh, that's beautiful. It's one of the adventure sessions here at HIMSS, and thoughtful. And as you point out, one of the rare patient sessions, patient-driven sessions.
And storytelling, I think, is a really impactful way of shifting the paradigm of healthcare, and one story at a time.
Sure is. All right, Max, Amanda, thank you.
Thank you.
All right, thanks for sharing your time and your story. Okay. Another perspective I want to share with you. Tim Putnam is Chief Executive Officer at Margaret Mary Health in Indiana, and he joined Lynn Barr, who's President and CEO of Caravan Health, based out there in California. And what they're doing is amazing. Crossing boundaries, crossing regions to bring affordable health care to people in ACOs. I think you'll enjoy this one. Hi, Tim Putnam, Chief Executive Officer of Margaret Mary Health in Batesville, Indiana, and Lynn Barr, President and CEO of Caravan Health in beautiful Lake Tahoe. I think you win on that one. I'm sorry. But this is a passion for you, bringing care to people in rural environments. Talk about the evolution of how you got to that point, Lynn.
Thanks, Adam. Well, you know, this all started when we started implementing electronic health records for rural providers across California. And we really wanted to make a commitment to not just put in the electronic health records, but to use them to improve care. So we thought accountable care organizations were really aligned with using this data for really meaningful things, and also our mission of taking care of our communities.
And Tim, for you?
Well, I mean, ours is fulfilling our mission as an organization, as a hospital. I mean, every rural or community hospital out there is charged with improving the health of the communities they serve, and getting involved in initiatives like the Accountable Care Organization or as part of the Affordable Care Act was really something that allowed us to be able to do that and move it forward.
Sure. So many of the professionals here are either doctors or IT professionals, entrepreneurs, et cetera. It's harder for many of us to understand the politics behind it, but was it really the Affordable Care Act that enabled this new structure to come into being?
In part, the Affordable Care Act. I mean, we all know, we all see and hear the statistics about the cost of care in the U.S. and how we're not getting the value for that. So this really triggered a transition from volume to value. We get paid to do stuff to people, not to make people healthier. So how do you incentivize people to be healthier? It's the best example I have is a friend of mine talked to our board of directors and basically said, look, when I was a kid, my grandmother had diabetes, and I didn't know what that meant, but I used to play with my grandmother, and one time I went to visit and she had to have her toe cut off, and I never understood why. But I couldn't play with my grandmother as much. The next time I go and I visit her, she had to have her leg cut off, so she's in bed. And he said all along the way, the hospital and the doctors were paid to cut off the toe and cut off the leg, but they were never paid or incentivized to keep my grandmother's diabetes under control. And that's what we have to move to. And if you're charged with improving the health of your community, this is something you're driven to do. It's trying to figure out how to do it. And the ACO, the shared savings program was a way to do that, but we had to partner with other hospitals. That's where I worked with Lynn to be able to find those other like-minded community hospitals to do it.
So it's about sharing costs and economy of scale?
Yeah, and more important, it's about sharing lives. You have to have about 100,000 lives in an ACO to reliably take risk. And so 75% of all ACOs have less than 20,000 lives. And when if they go into risk, they could be writing a check for 10% or millions of dollars for statistical variance. So we had to get rid of the statistical variance as well.
Right. You're in California, you're in Indiana. How was it that the two of you actually found each other, came together and said, let's bring our organizations under one roof effectively?
We were in a room in Washington, D.C., hearing what was going on and hearing the transition, and quite frankly, we were the two angriest people in the room.
Water seeks its own level.
You know, and we're sitting there going, this is where we need to go. Why can't we be part of it? And then Lynn really found a way to be able to bring multiple hospitals. She was in rooms with other people that were frustrated as well. How do you bring them together, and how do you get them to take a chance on this program that's associated with the Affordable Care Act, but goes the direction we want to go? So it's bringing like-minded people together, and that's Lynn's forte.
Everybody is so afraid of I don't want that person in my ACO because they're going to bring down my scores. And they don't understand that statistics are going to do much worse to them than any other participant can. So what we had to do was create a model of transparency and accountability, make sure everyone's managing their patients better than fee-for-service. We're all doing prevention. We're all doing wellness. We're all doing chronic care management, and we're doing good coding. And then if we do that, we have reliably beat fee-for-service every single year since 2015.
Okay, so I can understand now how you can compare the new system to the old system, old being fee-for-service. 10, 20 years from now, let's say we all move to value-based healthcare. What's the benchmark going to be at that point?
So if we all move to value-based healthcare, we'll be in capitation, right? So we're not going to be in ACOs anymore.
Right.
Right now, you know, it isn't about the benchmark. We have to be better than fee-for-service trend, right? I hear this from hospital CEOs all the time. How much do I have to forecast my loss, you know, because now we're managing patients, you know? And I look and I say, so you know what? We're bringing down, our costs are rising less high as fee-for-service by about 1% per year. But in the meantime, we're increasing outpatient revenue 14 to 17%. We're increasing inpatient revenue from 4 to 7% because this is the kind of care your patients love.
Now you sound like a business person, right? It's about margins.
It's well,
but effectively,
no margin, no mission.
Tim?
Yeah, it's the battle we fight. The chief financial officers say, all right, so if I give all these flu shots and I give all these pneumonia vaccines, won't that be fewer people that I've got coming in the hospital? And it's yes.
Right.
Yes.
And it's what you should be doing.
These people won't die for no reason.
Yeah. So, and it's that kind of mindset over and over and over again on a lot of things. But like Lynn's saying, it ends up being we do more colonoscopies. We'd rather do 100 colonoscopies than treat one colon cancer. We'd rather take care of the behavioral health issues and see the patient come in the ER time and time and time again. So the challenge was you're going to do all this health stuff and your hospital's going to dry up and blow away. But it really doesn't happen that way because you get the preventative services, and quite honestly, in communities like ours, you gain the trust of the patients. And once you have that trust, they know they're working for your best interest, not cheering when you get sick and have to go to the hospital. It really makes a difference. And that's where it drives up the other revenue Lynn's talking about.
Yeah, I love the way you just put that. Rather than treat one colon cancer, we're now going to have 20,000 colonoscopies, and we're going to make plenty of money on that.
Yeah.
But
I mean, that's the story.
Right.
I mean, you stop that disease in its tracks. Right now, we're looking at readmissions being a bad thing. How do we eliminate that? Soon we'll look at colon cancer as a bad thing. If you had a colon cancer, it means you failed somewhere along the process to prevent that.
We can
if you have
wipe
an
out
admission
colon
for
cancer.
pneumonia, it's the same type of thing.
You just said we can wipe out colon cancer?
That's right. In our communities,
diagnostically,
if everybody in our community has appropriate colorectal screening, they will not get colon cancer. We can wipe it out. And that's what we're trying to do. We're, you know, vaccines. We increased our flu shot rates and our pneumococcal vaccines, and our pneumonia admission rates went down 40%. 15% of those people die in the hospital. Right? That's what our mission is about.
The diabetic patient's a great example. If we can keep a diabetic patient's hemoglobin A1C in control, under 7 in the 6 range or something like that, then we keep the complications associated with that. Right now we treat them as just complications. But in the future, if we treat those as failures of our system to help that patient get their diabetes under control, we'll look at it differently.
Right. So I just want to say that every CFO and CEO's fear of going into this is it's going to hurt their hospital. We have 250 hospitals in our ACOs, 38 ACOs now in 44 states, and not one has ever left because they hurt themselves financially. So it's a myth. It doesn't happen.
Right. Wow. What an eye-opener. What a pleasure to speak with the two of you.
Thank you so much, Adam.
Thank you, Lynn. Thank you, Tim.
Thanks,
Thank you, sir.
And now, on the front lines of getting the word out from HIMSS, Jonah Comstock. He's editor-in-chief of Moby Health News and part of the HIMSS family. Great to have you here, Jonah.
Great to be here, Adam.
So, HIMSS actually bought Moby Health News, what, a couple of years ago? Mm-hmm. And you are now figuring out how to tell the stories to push what's happening here at HIMSS out to the general public. What's your sense for the coverage this year? It's a big one.
Yeah, well, it's great. We've got almost everybody in editorial and HIMSS media here covering panels, talking to people. You know, it's a great show.
Yeah,
so
it really
far.
is a great show. And one of the things we're doing this year that's new is HIMSS TV, because there's so many people who want to be here that can't, in spite of the fact there are 47,000, I think it is. Is that the number?
Yeah. Last I heard.
Yeah, I mean, it's and probably growing because there are always people who show up day 2 and day 3. Trends, and there's so many things that we've been talking about that I've noticed: security, artificial intelligence, putting patients first, value health, but telemedicine, which is kind of part of that value health. That's an interesting one. I think you've actually been writing about that.
Yeah, I did a lot of pre-show work. In Boston, we have American Well, and so I spoke to both the brother co-founders, Ido and Roy Schoenberg. Right. And I've been going to some sessions here at the conference too, and the trend I'm really seeing is a shift from telehealth as an offering that employers offer to their employees via payer, which is still very much out there, but now it's starting to be offered by the hospitals. They're partnering with telehealth vendors to offer their own virtual care, video visits, branded Mayo Clinic or branded Kaiser Permanente or branded New York Presbyterian Hospital. There have been a lot of hospitals sharing their success stories with that at this show, and I think it's going to be super interesting to see how those two models come together and which one sort of wins out in the market.
Well, it's a new revenue stream for the hospitals. I mean, certainly that's appealing, isn't it?
Yeah, but it's not just that. Telehealth also, I mean, it reduces readmissions, can potentially, people who are seen by telehealth don't need to come in, and you cut out waiting room times, you improve the patient experience, and even from a health perspective, I mean, the last place you really want to be when you're sick is a hospital, because you're going to catch other infections from other patients, and when you can see a doctor from your home, you can eliminate that too. So there's a lot of benefits, and some of them are financial, and some of them are just really patient experience benefits and even clinician experience.
Yeah, right. Is this part of the trend that we're seeing? Again, we talk about value health, and as opposed to fee for service, that a hospital would rather give 200 colonoscopies and have to treat one patient with colon cancer, right? I mean, it's the preventative aspect.
Yeah, I think that's definitely a piece of it. Although it's interesting you mentioned value-based care, because a lot of that conversation there is about payment models. And one thing that's holding telemedicine back, I think most people who work in telemedicine will tell you, is that those pieces aren't in place for reimbursement yet. So the value-based organizations, the ACOs, they're able to do sort of more experience and more deployment with this technology because it's the bottom line that's important to them, that those savings kind of directly contribute. Other organizations that are still fee for service are still struggling to make sure a doctor gets paid when they talk to you on the phone, gets paid when they talk to you on a video visit, on even like Kaiser Permanente is doing on a chat. And that structure is not quite in place everywhere yet.
No, it's not. I've had a couple of texts back and forth with doctors of mine, and I guess they just sort of consider it part of the service, but there'll probably come a point at which there's a number associated with that.
Yeah, I mean, it is. They're providing the same service that they do in their office. They're giving you your health care. So whether it's on video, whether it's on chat, they should be being compensated for that time, certainly.
Yeah, they should. So as you walk the floor, talk to vendors, talk to doctors, on and on, what are some of the other themes that you're excited to write about, the stories you want to tell?
Well, everyone's talking, I'm going to cue up Tom for a little bit for this one, but everybody's talking about AI and machine learning. I mean, that is the watchword this year at HIMSS, and I think the stuff they're doing is extremely exciting. Obviously, there's a little bit of hype and a little bit of fluff whenever you're going to talk about AI, but you know, it does intersect with telemedicine. Just on walking up here, I spoke to a gentleman from a company called First Derm that's doing video, dermatology through an app. You can take a picture of your mole.
Yeah, exactly. Right.
And it, at first they were using a real dermatologist that would look at it, and increasingly they're just moving to algorithms, because the algorithms are getting smart enough to look at your mole and tell you a little bit about what you might have.
Wow. Now you're breaking down all the walls. Boy,
Yeah.
that's amazing. And you're going to be writing about that, I would imagine, in an upcoming issue?
Yeah.
Yeah, I mean, that's too good not to.
Yeah, we've been writing a ton about AI and machine learning already. If you check the website or the show dailies that are coming out, went to a meeting last night that included the Mayo Clinic CEO, and a gentleman from IBM Watson, and James Madera, the president of the AMA, and they spoke a lot about sort of all the different ways that technology is changing what they do, and it's pretty fascinating.
Love it. Well, we'll be reading all about it in Moby Health News.
Great.
All right, Jonah, thank you.
Thank you, Adam.
All right. So Optum, one of our wonderful sponsors here at HIMSS, and a word from them.
Listen up, heart disease. You too, unnecessary ER visits. And hey, unmanaged depression. Don't get too comfortable. We're talking to you, cost inefficiencies and data without insights. And fragmented care. Stop getting in the way of patient recovery. And pay attention. Every single one of you is on our list. At Optum, we're partnering across the health system to tackle its biggest challenges. Optum, how well gets done.
Tom Sullivan is editor-in-chief of Healthcare IT News, director of content development for HIMSS Media. He's part of the team. Tom, good to see you.
Good to see you too, Adam. Thanks for having me.
Oh, always. So you are really the one behind a lot of the content that gets sort of filtered from what happens here on the showroom floor and sent out to the rest of the world. What excites you about this year?
This year, I think the most exciting developments are around machine learning, artificial intelligence. There's a lot of hype. There's some hope. We're starting to see use cases and clinical trials and operations emerge that really work. But most of all, I think we're seeing a foundation of connectivity and interoperability coming into its own, and that will enable a new generation of data exchange, but also clean data, the right data, so that it can be run against analytics, or rather analytics can be run against it for machine learning purposes.
Yeah, right. Now, granted, this is a healthcare IT conference, so you would expect to find people focused on data, but I've been intrigued by how many conversations I've had with people who are doctors. They were practicing doctors and have left because they wanted to have a greater impact, and they felt that actually healthcare IT data was the way to do it.
Well, there are a lot of doctorpreneurs, as they're affectionately known, and really, who better to take that mantle in terms of knowing what to do with the data, because they have that deep understanding of medicine and the healthcare system, how everything works.
Yeah, right. HIMSS 2018, I think, or HIMSS 18, I think this is actually the 55th annual conference. And this year, as you point out, it's really one where machine learning it's real. It's no longer just sort of a gee whiz thing. Are there any kind of case studies, specific ones you can point to, companies that you've met that are really leading the charge and they have something that's actually ready for testing?
Well, there are the big ones, of course. I mean, Google's Eric Schmidt came and he talked about what they're doing, and he actually made a kind of a guarantee that if we invite him back for HIMSS 2028 or whatever it's called then, he would bring a tangible product,
But we have to wait 10 years?
Products. We don't have to wait 10 years for this to actually happen, but he did say he would have it, and it was a pretty forward-looking initiative. So.
By the way, pretty impressive and wonderful, and that's why so many people come to HIMSS, right? Eric Schmidt, CEO of Google, giving the keynote here at HIMSS.
It was great.
Yeah, phenomenal. Who else besides Google?
Well, Microsoft, IBM to a certain extent as well. So the big players, and then there are, there's no shortage of startups that are bringing exciting technologies. And I spoke with an EHR vendor. I don't want to name names here. You can read about it in the show daily, however, who's talking about releasing a new version in the fall that will include telemedicine. It will also include voice assistant technology. So that's moving in that direction. And I think this year what we're really seeing, again, is that foundation of connectivity, interoperability, clean data. That's setting the stage for where healthcare needs to go.
You mentioned Dr. James Madera, the CEO of the American Medical Association. I spoke with him yesterday, and he told me that on average, I was just shocked by this, that a doctor spends an hour a day with patients and 2 hours a day writing. I mean,
yes.
You know, it's actually probably more like 5 hours and 10 hours, but I mean, 2 to 1, that is crazy. And I think what you're really getting at is trying to cut down that amount of EHR time.
It's certainly a big opportunity is to reduce the physician administrative burden by using new technologies.
Do we have a sense for, well, and you probably don't want to name names, but I mean, who's doing it best? And if you can't name names, maybe, just some...
It's not a case of not naming names. It's instead a case that I don't know that that's been determined. I mean, who's doing it best?
Oh, you're not taking...
Everybody would probably say that they're doing it best, but it's so early and we're in such a foundational state right now that I don't know that anybody could credibly claim that they're doing it best.
That's interesting, because I do feel like it's one of the friction points this year. Like, I feel like there are a lot of people who are complaining that it could be better, but like, I'm not seeing, the bright shining light that says, here's the way forward.
Again, it's early. I mean, I think what we are seeing is that way forward, even if there's not one person saying, or one company saying, I have the answer. These are complicated problems.
Oh, God.
Very complicated, big problems that have taken a long time to, it's not that they've taken a long time to solve, excuse me. People have been trying to solve them for a long time. I mean, if you think about, so the surprise guest yesterday was Jared Kushner.
Yeah, right.
And it was kind of fun to be in the room when he came on stage, regardless of your politics, because now they're saying the Trump administration has a plan to fix interoperability. And talking to people throughout the show, some of them say, well, they're just rebranding what was already in progress under the Obama administration, or rebranding what was already in progress prior even to Obama.
And trying to claim it and own it.
Trying to claim it and own it. And, other people are saying, well, great, the federal government is now making this a priority.
At least they're doing something, yeah, right. Were you in the room when he came in? What was that like?
I think people were surprised. People,
but like happily so, or surprised like, what's he doing here?
Well, a little bit of both, maybe, depending on people's politics. I don't want to get too deep into that right now.
Because the beauty of HIMSS is it's not about politics. It's about patients.
Very well said. I think the overarching emotion in the room was, wow. We didn't know he was coming. Everybody was there to see Seema Verma. Probably everyone is aware that he and Seema work closely, and they've held some White House meetings on EHRs and interoperability.
Yeah, right.
So,
wow. Gosh, Tom, we could go on and on, but
yes, we could.
I mean, there's just so much to talk about, and you really are the king of content here, determining what we all take away. So, thank you.
Thank you.
Okay. Klaus Doodle Pedersen is the CIO, the Center for Innovative Medical Technology at Odense University Hospital. He's joining us now. What a pleasure. Thank you.
Thank you. Thank you for having me here.
Yeah. You just talking about, isn't that amazing? Jared Kushner coming here to HIMSS. Eric Schmidt, former CEO of Google, coming to HIMSS. I mean, this is where people want to be. I mean, this is where the conversation happens.
It does. It does, absolutely. It is quite inspiring to be here because there's so much learning, so much knowledge to take back. But most of all, I like the interaction with the people who is here.
Yeah. What specifically, aside from just the opportunity to speak with people, what is it that's brought you here that you want to share?
Well, I come from a Danish hospital, so it's quite a different system.
Yes.
Both the way that it's organized, the way it's paid, and so on. But we are all facing the same challenges when you're looking at the demographic development and the lack of resources that we have, and how we are dealing with the patient's demand and the patient's needs. So it's a universal problem that we are facing. So it's always interesting to meet, learn, and maybe steal something with you back to the place where you're from.
Yeah, that's right. Single payer is something that this country has wrestled with back and forth and back and forth. Europe has obviously embraced it to one degree or another. What's your perspective as a European looking at the U.S. and how we wrestle with that notion?
Well, at least it seems to be much cheaper overall for the citizens to go to a single payer system.
Yeah, right.
We have a single payer system. It gives us control of the cost of the services that we are delivering, and it's equal access for every citizen to healthcare, which I personally find the right way to do it. It also gives us some of the challenges, because what we are facing, and one of the reasons why we are at HIMSS is that even though we are a public run and owned hospital, we still have the obligations to be efficient. So we are in the process of building a new hospital that will reduce our bed capacity with 30%.
Will reduce? You're building a new hospital that's smaller?
Exactly. And we have been reducing the beds in Denmark for the last 15, 20 years. Going down from, we had 160 hospitals, now we are down to 40, and going down to maybe 20. And it's a centralization process that is going on to increase the quality and reduce the bed capacity in that sense.
So are you making up for that through preventative care, so that people don't go to the hospitals, through telemedicine, so they get sent home faster?
You can say when we have 5 years to take out 300 beds, we need all the help we can get.
Yeah, right.
Which means that we use all the tools in the box that we have, and technology and supportive technology is definitely one of the ways that we are trying to cope with the issue that we have. Prevention, absolutely. That's the responsibility of the municipalities in Denmark, but it's something that is needed and we need to be a lot better at. But it's also a long-term investment, because you can start preventing today and you will see the results in 20, 25 years or something then. The key issue for us is actually establishing a well-supported, clinical-based collaboration between primary care and secondary care, so that the patients that we don't no longer see or have in the hospital are taken care of in a good way by the municipalities, the home care nurses or the GPs and so on. And that's the trick we are working with now, how to support the collaboration across the sectors. So we have covered the whole care continuum better than we do, and IT is an important part of that process.
Yeah, which is really part of the message of HIMSS. It's using IT, technology, data, breaking down silos and bringing people closer together, improving the format. Before I let you get back to the conference, when you tell U.S. hospital administrators here that you see at HIMSS that you're building a new hospital with fewer beds, how do they respond?
Well, the first time I was in conference, we were told that our aim is to keep patients out of hospital.
Right.
Most of them thought I was insane.
How are you going to get paid?
Exactly, and that's the you can say the good part of being a single payer system, because we get actually paid for the services that we're delivering, and then we are sharing the cost across who is actually have the responsibilities for that. So we will also reduce our budget.
Well, I was going to say R&D. It's kind of hard to get the government to be a willing partner on R&D, and that might be the downside of the single payer.
Yeah, well, that's in our case not so difficult, in the sense that it's more afterwards reflected in the reimbursement structures. So we can.
So it's built in.
Yeah, we can get, if we make good solutions.
Yeah.
They're also willing to pay for it. So if you save money in the hospital, the money gained can stay in the hospital to support the development of the quality or new services and so on. I think that when the day we open the new hospital, we will have, as I said, around 300 less beds, but we will also have 8% less budget.
8% less. Yeah. So the realities of the modern world.
Exactly.
Yeah, and a coping. Well, thank you for traveling all the way from Denmark, certainly to be at HIMSS and share the perspective with us.
Thank you for having me.
All right. All right. Well, it's wonderful to have you, and we have not met before, so we're just going to do this right on the fly. I'm Adam.
Hi, I'm Emma. Nice to meet you,
Hello,
Adam.
Emma.
Hi. Well, I'm spinning in my chair here.
Well, you know, it's we're perched up in a wonderful spot where we get to see a lot of what's happening here at HIMSS. What excites you about HIMSS 2018?
Well, there are so many education sessions going on. There's over 1,000 vendors on the HIM floor. I, as an investor, and as someone who's an investment banker, I'm looking for companies that are looking to exit the market, wanting to sell themselves to larger enterprises, and I'm also looking for early stage investments. So I like to go
really both ends of the spectrum.
Both ends of the spectrum. So I really enjoy going through the HIMSS floor, and I like to go go around Hall G, which is where a lot of the smaller companies are, a lot of the innovative companies, and I like to sort of trawl through and find some exciting innovations. So that's what I'm doing here.
Is there a sort of a theme to the startups that you're seeing down there on the G area, floor G?
Actually, a lot of them are consumer facing, and we've seen the industry really evolve. We've had a lot of EMR companies and then data analytics, and now we are seeing more companies come up, and how are we going to engage the consumer to change their behavior? And that is really exciting to me, because everything we've seen so far in digital health is a lot of it's been focused on what happens within the hospital.
Yes.
So I like now that we're trying to engage consumers to change their behavior and be accountable and responsible for their health.
Yeah, that's a huge theme. And I don't mean to sound so mercenary, but you are an investment banker. What sells right now?
So that's a great question. And I look at this from two ends of the market, so I've almost got to answer two questions separately.
Please.
So right now, formerly innovative companies were interoperability, telemedicine, clinical decision support, okay? And they were all the big innovations 10 years ago, where I would have been putting angel money in. Now, they're the mature companies that are getting ready to be acquired by some of the larger companies in the market.
Wow.
And so these earlier stage innovations are now mainstream. Most hospitals are doing telehealth. They're all figuring out their interoperability strategies, and a lot of them have implemented clinical decision support. So I feel as though they're beyond the innovation phase, and they're now in the growth and mainstream phase. Now, in the innovation phase,
and forgive me,
sure.
How many of those companies are public versus private?
Well, most of them are still private.
Yeah, they never went public.
That's right.
They're private, they're bigger, and then they get bought.
That's exactly right.
So for investors, it's hard to participate.
We are seeing, publicly traded investors, absolutely. Yeah. It's mainly the VCs who are getting to cash in on this environment.
I'm a stock guy. I'm a publicly traded company guy, so I feel left out on this wonderful upswing.
So there are some publicly traded companies in this space, and they've been doing a lot of the acquiring. So I expect that you will have opportunity to participate with some of these earlier innovative companies that are now more mainstream in some of these publicly traded companies.
You want to name names?
No.
No. All right, fair enough. And then I interrupted you. You were about to talk to innovation. In other words, the new kids on the block.
Yeah, the new kids on the block. As I said, there's three areas. One of them is quantified self, so all the apps where we're collecting the data. One of them is patient engagement platform. How do we engage the consumer? How do we make the consumer accountable for their health? What platforms are out there to really get the consumer to engage and take care of their health? And there is a great company called BeWell on the floor I came across.
BeWell? All right, should I write this one down?
Sure.
Public?
Not yet. Small, just
I'm writing
really
it down anyway.
BeWell. BeWell. Letter B. .well.
Oh, letter B. .well.
Yeah.
All right, tell me about BeWell.
So I really like them because they are collecting all the data. So when you go to the doctor, you have your electronic medical records, you've got all your appointments, you've got your prescriptions. So as a consumer, I want access to my records. And if I'm going to see multiple doctors, I want one place where that's consolidated. I want my dental information in there, right? And also when I get a prescription, I want to be alerted that my prescription's ready to pick up, and I want to see coupons so I can see where I can pick up where's the cheapest place to go and pick up my prescription. Now, ultimately, in an ideal world, I'd like my prescription to be delivered to me without ever having to think about any of that, but we're not quite there yet. We're getting there, right? So the other part is that if I need an appointment, if I'm missing an annual checkup, that app will remind me. If my kids are missing an immunization, I don't have kids, but if I had kids and they were missing an immunization, then this would remind me. But it also gives you timely content. So if I'm following a health and wellness program, if I'm trying to stop smoking, if I'm trying to drink less, this app will help guide and incentivize me toward those healthy behaviors. So what I love about BeWell is it really is thinking about all consumer engagement with the healthcare community.
So I had a conversation about a half hour ago with two ladies, and I said, oh, what you're talking about, and you'll get this being a Wall Street banker, I said, you're talking about creating a prime broker, a clearinghouse that brings it all together, right? If I have an account at Morgan Stanley, an account at Goldman Sachs, account at JP Morgan, there are three different places. I want it centralized into one location, and you're saying BeWell kind of does that for me?
Absolutely.
Love it. We should all be
It's really exciting.
Finding Be Well companies.
Exactly right. And I think they have the opportunity to be the unicorn in the market.
Wow.
And that really excites me. And I really hope the company grows up to go public so that you and I can buy stock in it.
Please. That would be outstanding. And we'll talk about it at HIMSS 2022.
Yes.
Emma Cartwell of the company is Capello Global?
That's correct. I'm an investment banker at Capello.
Well done. And thank you for joining us.
Thank you very much.
Really appreciate the perspective.
Thank you.
All right. Jennifer Esposito is Worldwide General Manager of Health and Life Services at Intel. Yep, big tech is here in a big way.
Hello, I am here with Jennifer Esposito of Intel. Thank you so much for joining me today. How are you?
Great, thanks for having me.
Excellent. So tell us a little bit about Intel's involvement in the health and the life sciences area.
Well, you know, Intel's a technology company, so people don't always understand why we're interested in healthcare. We're an ingredient company. The job that my team and I do is really work with the healthcare industry to understand their unique challenges, their business issues, so that we can really understand how we can take our technology and apply it to those unique use cases. And so we'll take the information we capture from customers and end users and our partners and bring that into our engineering business and really understand how we might need to evolve as we go forward.
Excellent. So how are you evolving going forward?
Well, we're doing a lot of work with partners, both traditional technology partners that Intel normally works with, but also with industry-specific partners in healthcare. And so we'll do things like help with software enablement, optimize code. We'll put together different parts of the ingredients that we have to stitch together a more end-to-end solution. And we'll also help bring different partners to the table that might also be uniquely able to solve those challenges.
Excellent. So Jennifer, I know that you talked about, obviously, artificial intelligence was a big item here. So tell me a little bit about that in Intel's involvement.
Well, we are doing a lot of work in artificial intelligence, and in my talk I talked about machine learning, deep learning, and cognitive computing. Yes. So we really think that there's a much broader sort of perception out there of the different ways you can use advanced analytics. And from a healthcare perspective, there's a massive amount of untapped data that needs artificial intelligence, and I think it's not one type versus another. I think we've really got an opportunity here to solve some of these core, both clinical problems and even business and operational challenges using artificial intelligence.
Excellent. So tell me a little bit more about that. I know some people might be concerned that artificial intelligence could take over their jobs. So what are some of those common misconceptions that you could share with us?
Yeah, I mean, I think that, you know, we get that question a lot. Is it, it's going to replace a physician? I don't think it's going to replace physicians. Actually, I think it's going to bring physicians even more opportunities to really take advantage of their true expertise, because they're going to be able to zero in on the patients and the conditions that really need their expertise the most. And simpler things can be taken care of by AI or other clinical specialties. But really, from a physician and a nursing perspective, I think AI holds the promise of allowing people to work at the top of their licensure and really focus in on the people that need their help the most.
Right, so streamlining in that case.
You know, really pinpointing, triaging, I mean, is a word I use a lot, and I think that's really important. Instead of a radiologist analyzing every image, there are some where it's a very simple scenario of positive versus negative, and there's others that require a little bit more deeper look and capability, and I think that's true across different specialties in healthcare, and you're going to see that really take hold versus do away with a physician. I don't think that's going to happen.
Right, I don't either. So tell us one thing too about artificial intelligence. If there's one thing that people should know, what is it?
Well, I think that, you know, one of the things I talked about in my talk this morning is that it's not just AI in terms of one single definition, and I think people need to be aware of the fact that for different use cases you may need to deploy multiple types of AI to solve the problem, and I think that's really important. I talked about what we call complementary learning, and complementary learning in my mind is combining machine learning, deep learning, and cognitive computing to solve unique challenges versus trying to pick one versus the other to solve it.
Right, absolutely. So thank you so much for being here, Jennifer. You were wonderful.
Thank you. Great to be here and really enjoyed the conversation.
Excellent. Thanks, everyone.
We are so excited to bring you a conversation that may go down as one of the best here at HIMSS 18. We're joined by three gentlemen who are not only passionate about healthcare, they are also politicians at the forefront of trying to get this thing right. Governor Jim Douglas, I should say the former governor of Vermont, joins us. Delegate Daniel Moorheim, who's actually a practicing doctor, an emergency room doctor, is a state delegate, District 11 from Maryland in the House of Delegates, and Representative Jesse Topper from the State District 78 in Pennsylvania. Gentlemen, what an honor to be with all of you. Thank you.
Thank you.
I love bringing public and private groups together because I feel like there's this incredible opportunity to create partnerships, and it's the sort of thing that we always dance around, but somehow we never get it right. But maybe this is an opportunity where we can start bringing people together, healthcare, right? Patients, doctors, and now government. Governor, if you could talk about some of what you were part of up in Vermont, because Vermont has a much more public-private willingness than so many of the other states.
Well, we try to encourage that, of course, and it was about a dozen years ago that we put together an organization called VITAL, an acronym for Vermont Information Technology Leaders, to bring, as you suggest, the private sector together with state officials to work on HIEs, patient records, and interoperability among those data. It's still a work in progress, to be sure, but because of the small size of our state, the close-knitness of our communities, we have an opportunity, I think, to really make it work. And for not only that reason, but some others, we've been deemed in the last decade the healthiest state in America for quite a few years.
Vermont is the healthiest state?
Well, not this year, but on my watch.
It might be the most beautiful state. Under your watch, yes, it was the healthiest.
So we think we can continue to make some progress. As you know from your experience on the slopes of Stowe, it's a place where we value recreation, outdoor activities, living a healthy lifestyle, and if we can use data to facilitate the healthfulness of our state, I think it's going to be a very successful effort.
Yeah, Congressman from the great state of Pennsylvania?
Just representative. I don't need to get the promotion.
Okay, well, we'll give it to you if you want, but I appreciate the honesty. What's brought you to HIMSS?
We were able to have a bill a couple years ago that allowed Pennsylvania to join the Interstate Medical Compact, so allow our physicians to be able to practice telemedicine across state lines, which in an area like mine, a rural, underserved area, telemedicine is the future. It's what we need in terms of having accessible and affordable health care. So I was really excited that we were able to work with HIMSS, get that legislation passed. It was passed unanimously in the House, the Senate, signed by the governor. Not too many bills that can do that anymore.
Nothing ever happens unanimously.
Right. We were excited about that and the opportunity that telemedicine provides, not just for our constituents, but also for surrounding states that use our facilities. The great Children's Hospital out of Pittsburgh, Children's Hospital out of Philly, Lehigh Valley Network. We have wonderful facilities in Pennsylvania, and we're happy to export that as healthcare as well.
How hard was it to cross state lines in what you were doing with that?
It's hard, and it's still hard. We're still dealing with some issues with background checks with the FBI that we're trying to get right. Have a meeting with the Attorney General's office next week just to try and make sure we're able to actually get these expedited license out there so that doctors can practice across these, what I call imaginary barriers, but they're still great barriers.
We drew them, but
right.
Yeah,
but
if we can redraw congressional districts, we ought to be able to redraw lines to help people.
Right now, yes.
Well, that's not going so well either right
That's
now.
right. Well, yeah, we got to have some fun with that. Doctor, you're in a unique position because you are both a member of the state legislature in Maryland and you're a practicing emergency room doctor. What's that perspective like for you?
Well, I try to bring both together because at the end of the day, the whole purpose of the health information system, and HIMSS is just amazing, by the way. I'm so impressed and met so many interesting people. But the whole purpose of it is to facilitate the transaction between the provider, doctor, nurse, social worker, whatever, with the patient. And so you really want to have all the data there easily, quickly, and in a usable way, because we're spending, however, a little bit more time on the computer that I would like, and most of my colleagues would like, and we'd rather be focusing on the patient and using the data to facilitate a meaningful dialogue where there's time and space in order to engage in good conversation. So I've tried to bring a clinical voice to this discussion as well.
Dr. Madeira of the American Medical Association, the CEO actually, commented to me yesterday. He said on average, the AMA has found that doctors spend 2 hours of sort of back room work for every hour with patients. Has that been your experience as well?
I think that's generally true. It's different in the different fields that you're in. Emergency medicine, I work at a big urban trauma center in the middle of Baltimore City when I'm not in my legislative duties, and every patient is new. So if we could get more information about them, whether through the prescription drug monitoring program or the medicines they're on or their past history through the health information exchange, it would greatly facilitate care. But the other point I would make is I'm also the one, or me generically, are the ones who actually enter the data. And there's some real issues.
Should you be doing that?
Well,
a talented doctor? You studied for 14 years? I mean, aren't there people who can input the data for you?
No, because of the way the charting systems work, somebody has to review it in the end and make certain final decisions based on ICD-10 codes and other kinds of things, which drives the data that others use not only for billing, but for public health decisions. And I will tell you candidly that there's a lot of issues with that. Not because we don't care, but because the system is very difficult to use at times. And that's why you hear things like 2/3 of the time is spent on computer time and one-third of time spent with patients. That should be flipped.
Governor, I see you leaning in as you're listening.
Well, exactly. We want to make it as efficient as possible. We want to transmit the data across state lines, and I think the work that Jesse and his colleagues have done is critical. The Interstate Compact is pending in the legislature in Vermont now. I often note that the second largest hospital in Vermont is in New Hampshire in terms of the number of patients, and so we have to break down those artificial barriers, as you noted, Adam, and make this more possible.
I just want to remind all of you out there, we're listening to and honored to be joined by the former governor of Vermont, Jim Douglas, Delegate Daniel Morheim, State Delegate District 11, Maryland House of Delegates, and Representative Jesse Topper, State District 78 in Pennsylvania. Again, gentlemen, thank you. We're just so excited that you're here at HIMSS this year. ACA has gone through so many different changes, and I think we're all trying to figure out in real time, but ultimately, what do the changes that are, again, happening in real time mean for patients? And Representative Topper, if you want to try to address that, how's Pennsylvania dealing with the shifting macro scale of ACA?
As a member of the Health Committee, we're dealing with it really almost every year since it's been passed, and there's tweaks that go on. And the unfortunate thing about working in the state, as these gentlemen can attest, is a lot of times we're reacting to what happens at the federal level. And with so much flux at the federal level, it's been very difficult. But we try and do the best we can with the information that we have and make sure, I think one of the biggest things we've tried to do is make sure our constituents are aware of the changes going on at the federal level, and then trying to provide them the information with how that will most likely affect them. But it's difficult, and I would say anybody who says that they have an idea of exactly where it's going is probably wrong.
No, I don't think anybody does, including those in Washington. Do you think it's easy, and I'll lob this out for whoever wants to answer first, do you think it's easier for states to tackle these issues rather than the federal government and go directly to payers and providers?
Well, in many cases, and I'm glad that states are represented actively at HIMSS now, because so many health decisions are really state decisions, not only participation in the Affordable Care Act, but everything from Medicaid, hospital regulation, insurance regulation, all the licensing and provider issues, including the Interstate Compact, sexually transmitted diseases, medical cannabis, medical marijuana, end of life, reproductive rights and abortion. All those things end up being state issues. But I do want to make this point. Whether we have, at the end of the day, a national single-payer system or everybody's on their own, there are core clinical drivers that drive healthcare. Emergency rooms where I work are the source of 80 to 90% of hospital admissions. That's where people get in the hospital.
Is that a good thing or a bad thing from your point of view?
That's the way it is. Oh, it's a good thing because we got a lot of stuff out of the hospital, but elective surgeries, but people end up, that's where the decisions are made to put them into the hospital, and there's some strategies that can reduce that. I'll just give you a few very quickly.
Please.
End-of-life care.
Right.
If people would complete advance directives, free legal forms, that would make a huge difference. Addiction issues make a huge difference, not only in healthcare, but crime. 80% of crime is addiction-related in the United States. Obesity and lifestyle. People got to get in better shape. We have too many diabetics. Preventable trauma. The demographic now is an older woman living at home alone, falls down, breaks her hip. When I started as an ER doctor, I saw a lot of people from fender benders with injuries. We don't see those now because we've got airbags and safety seats and baby carriers and all that stuff. So there's some strategies to identify what's going on in the community. Regardless of the payer mix, you're going to have to address these core clinical drivers of healthcare.
And Representative in Pennsylvania?
Well, look, I mean, let me be very clear. Unless it's foreign policy, national defense, or infrastructure that crosses state lines with roads, the states can do it better, and we should be doing more of it.
I have the honor and perhaps the challenge of serving as chairman of the National Governors Association when the ACA passed. And there was a lot of concern on the part of governors across the political spectrum that the federal government was bringing its heavy hand into this area that has traditionally been the province of the states. Obviously, they are a significant payer through the Medicaid program and Medicare, but I think, as was famously said, the states are laboratories of democracy. 4 years before the ACA, we passed a bill in Vermont that ultimately reduced our uninsured rate by a quarter, and we did it on a bipartisan basis. So I think states really can get the job done.
And we did that too in Maryland on a bipartisan basis. In fact, we had Republicans defending the bill on the floor of the House, even though it was a Democratic majority, but the Republicans felt strongly enough about it.
Well, patient rights, that's certainly something where everyone can get behind. Gentlemen, I wish we could keep going. This is I mean, we can't tackle this possibly in 12 minutes, but unfortunately it's all the time we have. Doctor, Governor, Representative, thank you.
It's been great to be here. Thank you.
All right. We're going to listen now from John Whalen. He's Executive Vice President of HIMSS Media. There's so much to talk about what we're doing this year. HIMSS TV is brand new. It's our 55th annual HIMSS, and yet we've never done TV before. I hope you're enjoying all the programming we are bringing directly to you wherever you are. John, the 55th annual HIMSS, I think you're setting a new record for attendance, aren't you?
Yeah, no, it's early days, first full day today, pre-conference workshops and everything, and the numbers are really good, pacing well ahead of last year, which was one of our biggest events. So we're expecting, if not a record, but a fairly good event this year.
And the people here are so passionate about it. You walk into the room, I mean, you feel the energy. They want to be here.
Yeah, it's always amazing watching people come for the first time. Right. You know, when they actually get to see what it's all about. And you get to see the whole world of healthcare and technology on that floor, and people from all over the world come. It's a global conference,
right?
And the kinds of people that come, you know, it's the world's best and brightest minds, doctors, physicians, technology innovators, people that are sort of really engaged in tackling the big problems of healthcare in really creative ways. So the energy's huge, and what you see on the floor is, you know, contingents from all over the world that come to share these ideas and this knowledge. So it's a really amazing event. It's unique. It's really unique.
Yeah, it really is. So how do you actually try to organize all the different vendors, all the different participants who want to come? It's not easy.
No, it's not. So to participate as an educator, it's a really rigorous process. It takes all year to build the program. The program is vetted by, you know, all sorts of subject matter experts, research in the field, feedback from the members, the volunteers, the community.
And it's substantive. This is not big picture stuff. People here know what they're talking about.
Yeah, they do.
Yeah, the audience expects it.
They do, yeah. And so the quality of education is really high.
Right.
So there's a trade show floor, which is massive, and where there's a huge amount of conversation goes on. Last year, we think over 400,000 conversations took place in 4 days. So that's one piece of it. At the same time, there's over 2,000 hours of education. So thousands and thousands of people are going through those education sessions, taking with them ideas and practices, best practices, and knowledge that they can apply back home in their institutions. So,
yeah. What do you think the themes are this year?
Innovation, I think, is a big one, obviously. But that's more of a sort of a thing that runs through the events every year. This industry thrives on innovation. It depends on it for two main reasons. One is to sort of pioneer new ways of tackling some of these huge problems that face healthcare and today. And the second thing is you know, innovation is a major way of controlling cost. You know, if you can actually figure something out and do it in a creative way, it can end up saving you a lot of money in the long run. And particularly for hospitals and healthcare institutions, you know, doing that, innovating and eliminating expenses is a huge problem and a huge challenge.
Well, one of the things I've noticed is breaking down silos, right? If you can somehow break down the silos, then the information can flow. That's a cost save right there, isn't it?
Right, oh, absolutely. And I think some of the other themes that you're going to see this year. Cloud is a very significant portion of what we're doing here. AI. So we had a show today where they have standing room only. 8:30 in the morning, people literally packing the bags of the halls to tackle that one. So that's a big theme this year too. And I think the other thing too, there's a really big theme this year, which has always been here, but it's probably more prevalent than ever before, is the global conference. This is truly a global conference, global solutions, lots of people involved in doing that. So that's a big theme that I think has emerged this year and will be a dominant theme for us for the next few years as we build a global aspect of the conference. Yeah.
Sure. Well, one of the things you're doing to make it more global is HIMSS TV. This is a first.
Yeah, absolutely.
How'd you decide to do it?
Well, I think the idea has been, kicked around for quite some time. The audience that comes here, it's a huge show. I mean, as I say, over 45,000 people come. But most of the people that come are one of two people that come from every department or place or workplace across the world that's engaged in healthcare and technology. So there's a huge interest back home in what's going on at the show. And they used to rely on things like emails and the news that we post and everything else. But TV is a way to bring it home right away.
It's engaging, right?
Very engaging.
Yeah.
And I think it does a really good job of capturing the energy that you see at the show.
I think so.
Yeah.
I mean, we've got the sound of people. They're walking by as you and I are trying to speak. Sometimes we have to shout a little bit over them, but that's kind of what you want.
Yeah, exactly. Yeah, exactly. Yeah. So I think the energy is a really important thing. Also, the other thing too is that the way people are consuming their content now.
Right.
Video and TV are huge parts of the way that people consume their content, especially their news. So all those things together made perfect sense to try a TV thing. So here we are in our first year, and it's we're very happy with the results so far.
We certainly are. So this content, for example, our conversation, that gets pushed to people via email, it's on social, it's on websites, it's playing in the elevators of the hotels, on and on and on. And it's really going out to as many different places you can send it. And look at that, people are already trying to find you.
Yes, exactly. So.
That's good, you're man in demand.
Yeah, no, absolutely. So, and I think, HIMSS operates in over 52 countries.
Right.
And has a massive global audience. We sort of connect with people all over the world all year round. So with TV, I think it's a more intimate way of us connecting with that global audience day in, day out. So we're pretty excited about it.
Sure, well, we're going to let you go connect with your iPhone and your iWatch, et cetera, et cetera.
Exactly.
All right, John, well, congratulations. 55th annual, and as you said, record attendance.
Yeah, thank you very much.
Well done. We'll see you in the We are joined now by one of HIMSS social ambassadors, Colin Hung. He is the Chief Marketing Officer and editor of healthcarescene.com. Colin, thanks for being here.
Thanks a lot.
So you've been working the floor. Again, you're a social ambassador, so you're tweeting out, you're getting the word out. What excites you?
What's exciting for me this year at HIMSS is being the focus on practical innovation. So unlike prior HIMSS where it's more, hey, what's coming down the road 3, 4, 5 years from now, this year it's all about, hey, this is something I can implement today. And I'm really excited to see a lot of that stuff on the show floor.
So is this more about not to sound trite, but small gestures as opposed to grand gestures?
Yeah, I think so. I think, first of all, I think it's shown in the exhibits. I think they're a lot more toned down, a lot smaller than before. I think that's a good thing. I think what they're really focusing on is, hey, what can we do today as opposed to what can we do 5 years from now?
Yeah, right. Yeah, that's a thoughtful approach. And what specifically have you seen that looks promising?
So there's a couple of things. For me, what was interesting is there's some companies here that you wouldn't expect to be here. An example would be Windstream, a company that not a lot of us have heard of in a while.
Well, it's an old telecommunications company a lot of people thought was dead.
Exactly.
You only bought it because it had a high dividend. Literally. All right, I'm a stock guy at heart.
There you go. But what's exciting for me is that I had a conversation with them where they're really focusing their play on infrastructure to power the AI, to power the machine learning, to power all those kinds of tools. You're going to need some good infrastructure. And they really put a focus in helping organizations build that infrastructure because they got an expertise there. So they're not as glitzy as some of the other new entrants from other industries, but they're doing something that's really, truly implementable tomorrow.
Well, yeah, fascinating. And DirecTV is here talking about how you put HIMSS TV type programming in doctors' offices. And what a fascinating concept. Or even if someone's admitted to the hospital, doing a video that helps the person, figure out what is going to be happening. I mean,
exactly right. And another example would be a company called Zebra. Well-known Zebra, like the animal.
Yeah, like the obvious.
So what they do is they do tracking, and they've done it for years in the retail space. They've done it for years in the logistics, transportation, and now they're applying that to healthcare. So they've got this technology that works extremely well in those spaces, and they're applying it to here, to beds, to patients, to assets, and they're now able to give that insight that they're able to give trucking companies to hospitals.
Are these like SKU codes, or are they chips, radio frequency chips?
Both. They have scan technology that was formerly Motorola. They also have chip technology with the RFIDs and all that kind of stuff. So yeah, but it's tried and true technology that's just being applied in healthcare.
And all that's here at HIMSS, a healthcare IT conference.
Exactly. And I find that exciting.
Talk about big surprises. What do you make of what Apple is doing now?
It's very interesting. We recently had a tweet chat. It's a tweet chat that I run called HCLDR. And we crowdsourced that question. Is the entrance of Google, Amazon, Apple into this space of healthcare, is that a good thing or bad thing?
Yeah.
And I think the answer that came out was we're cautiously exuberant.
Cautiously exuberant.
Exactly. So on the one hand, people are very excited for that outside-in perspective. What can these guys do who are so good at the consumer
Especially
side?
in Apple, which puts the customer first. So if you can do that, you can put a patient first.
Exactly. So can they bring that same design thinking, that co-design thinking into healthcare? It's so needed. But on the flip side, a lot of people were worried, how does this scale? Is this only going to be applicable to companies like Apple and Amazon and Google, where there's such a competition for talent, and healthcare is now going to be a competitive weapon to attract that talent? Does that scale to your to an organization that isn't quite in that same space? So I think that was where the concern was, and also could they overshoot? There's a lot of complexity in healthcare. Are they really going to overshoot, kind of promise too much? And so it was that was why I said a little bit of cautious exuberance.
I remember a couple of weeks ago when Amazon announced that it was going to team up with JP Morgan and Berkshire Hathaway, Warren Buffett's Berkshire Hathaway, to try to figure out a comprehensive healthcare solution, insurance, for its 1 million employees. The news was a buzz for about 2 days, and then it moved on. But in your world, where you focus on issues like this, specifically within healthcare, is that still percolating? Are people still talking about that?
Yeah, I think so. I think it's sort of, you got that initial buzz, right? It was like, wow, they're getting into this space. But now I think it's sort of, okay, like we've heard these kinds of announcements before. Let's kind of wait and see what exactly they're going to come up with. What's the actual plan in place? It's almost like a policy announcement, really. And so now I think we're kind of all waiting, going, let's see the details. So I think we're all excited about it because there's potential there. But I think we're kind of letting it percolate a little bit more before we kind of cast a lot of judgment.
It's still unsure. All right, so when you leave me, you're going back out to the floor, I would imagine, walking around. Who are you going to go talk to?
I'm going to talk to a couple other companies. I'm going to talk to a company called Point Click Care. This is their first time here at HIMSS, and I'm excited because it's bringing other parts of the healthcare ecosystem into play, into focus.
Such as?
So they're focused on long-term post-acute care. So a lot of HIMSS has been always focused on hospitals, clinics. Here now we're starting to get into mental health. We're starting to get into home care. We're starting to get into long-term post-acute care. We're all getting older, and those are areas that haven't gotten quite as much attention from the technology community in the past.
And if people want to follow what you're putting out on social, where do they do that?
So you can follow me on @Colin_Hung. That's on Twitter, or you can come to see me at hcldr.org.
Okay, so Colin. I should say @Colin_Hung, H-U-N-G. And I would imagine you're also going #HIMSS18 on a lot of your stuff.
You got it.
So worst case, you just go there.
You'll see me out there.
All right, we'll see you out there.
Thanks a lot,
I'll be out there myself.
All right.
All right, Colin, thanks. All right. Well, what a surprise. Tell me all about you.
Okay. My name is Yuri.
Yes, Yuri.
And I'm a medical doctor as well as a director for Health 2.0 Japan. So basically, the half of the week I work as a clinician. My subspecialty is the plastic surgery, but I do the home care medicine. So mainly I manage the bed sore for elderly.
And what has brought you all the way from Japan to HIMSS?
Oh, to HIMSS because last year Health 2.0 was acquired by HIMSS, and now we are collaborating each other.
Love it.
Yes. So, yeah, and then because HIMSS doesn't have the Japan division, we're kind of trying to see how we can collaborate in Japan or whole Asia.
Collaboration is certainly one of the themes this year, and maybe more willingness. I wonder if that's technology. And Japan is in so many ways so much more ahead of the U.S. in terms of sharing and people being connected with one another. Can you comment on that, the perspective of Japan versus America?
What do you mean by connected?
Well, connected in that everyone in Japan is digitally
Yes.
connected, and it's just part of the culture.
Yes.
And so many of the tech companies that pioneered all those technologies are Japanese. So I think there was just a greater willingness or an acceptance off the bat.
Yes. Yes. So by context of connected to the digital devices, yes, we are pretty much more connected because, well, most of the population, they have iPhones or the all electric devices. But in terms of the healthcare, that's totally different.
Yeah, well, that's true. And one of the things I've noticed as I talk with people is, and I pull it out, I've got the iPhone 10.
Yeah.
It's absurd how big it is, smaller than my old 6.
Okay.
But that somehow this thing could be a gateway to health, whether that's texting with doctors, whether it's collecting data, whether it's storing my data. I'm just fascinated by this thing, a telecommunications device, maybe being my gateway to health.
Yes.
I haven't quite wrapped my head around that yet.
Okay. Yes, most of Japanese people, especially for elderly people, that can be the gateway, but it haven't been the gateway yet.
Right.
Because, well, historically, the face-to-face communication is the base of the medical clinic practice, right? And it's still for now. And more, I should say, the digital devices are just helping tools, for sub-tools for medical communication. That makes sense, yeah?
I love it. So as you walk the floor here at HIMSS on day 2,
Yes.
What are some of the booths that you want to go visit? Who are the people you want to talk to, and what do the conversations sound like?
Okay, I'm very much interested in data integration. Because of the aging population burst in Japan, there is the governments are now leading to put patients into their home, back into their home from the acute hospital, chronic hospital,
Yes.
even the nursing home.
Yes.
But they want patients to stay at home.
Well, same in this country. I mean, that's one of the things we're seeing. And then there was a gentleman from Denmark who was just talking about building a new hospital that has 300 fewer beds for this very reason. They want to get people out of the hospital back home.
So, but the problem is that the data just goes everywhere.
Say again, the which?
The data.
Yeah, the data goes everywhere.
Well, actually, the cloud-based EMR system has been imported 3 years ago, just 3 years ago in Japan. So it's quite new for us. The idea of the EMR is
right.
So, but now it's rapidly growing. The market is growing faster. But like I said before, the data is everywhere, and we have to integrate those because they want to stay at home. But if physicians don't know how they live at home, then we can't do anything.
Right.
So, and a nursing care home, like how they do the rehabilitation, how they treat patients for the cognitive reason and those kind of things, because the dementia is a big issue as well. So we have to integrate all of those: hospital, nursing home, and home, patients, family.
It's the same. It's the same in the U.S.
Yes.
At the end of the day, they're patients.
It's the big issue.
Yes, it is. Thank you. Thank you for being here.
Thank you.
Wonderful perspective. All right. Talk about perspective. Bobby Juergens is Director of Healthcare Sales East at Lenovo Health, and Wyatt Yelverton with Health Solutions Executives at Lenovo Health. Interesting conversation that happened here at HIMSS. Take a listen.
So as a hardware solutions technology company, we see a couple of areas where we can partner with the providers and address a few challenges. Number one is we shift from this volume-based to value-based care system. Solutions like telehealth, telemedicine, remote patient monitoring are becoming much more prevalent and much more necessary to have discussions around. Number two, how can technology help improve patient experience, promote that patient engagement, and really that patient engagement all the way through post-discharge into a virtual care setting? And then number three, these care providers, they need constant, always-on access to that patient data. How can that technology help deliver that? And obviously that patient data has always got to be protected and has always got to be secured. Well, first and foremost, mobility, clinical mobility is king right now. As opposed to the old school of bringing the patients into the care, now it's about bringing the care to the patients wherever they may be. So these clinicians need devices that are rugged, secure, mobile, and flexible, whether it's the device that they're using inside the brick and mortar walls or whether that's the device that's going out into the patient homes or into the nursing homes. So we've got to be mobile, we've got to be flexible, and we've got to be secure.
Really, the accessibility to patient data is becoming a pivotal ability for providers, for ancillary care staff to really care for patients and to deliver care in a personalized way that's relevant for that particular patient's needs. Ultimately, what we're looking for in technology is the ability to freely move data across the care continuum, whether it be from a clinic to a hospital atmosphere or from that facility out to a patient's home. It's pivotal to be able to make insights that are relevant to a patient in a continuing and ongoing way, such that as the patient's needs evolve, we are going to be there not only to be able to react to a patient's expectations, but to anticipate them and provide what it is that they anticipate of us as professionals. Innovation's really designing the future of how it is that we're able to deliver care to our patients. When we think about sensor technologies that are able to make clinical grade diagnostics outside of a medical facility, or new emerging technologies like AI and AR that not only allow us to interpret a patient's health and well-being on a completely different scale, but allow us to make decisions about delivering care to our patients wherever they happen to be. Our goal ultimately is to be able to facilitate that transfer of care, not just necessarily from a facility to a patient's home, but to make the care process ubiquitous wherever the patient happens to be.
Well, Lenovo's legacy was built on innovation, our relentless pursuit of innovation. We've got to be quick, we've got to be nimble, and we really have to stay ahead of this market. We're also committed to making sure that our customers thrive in this value-based market that we're shifting towards. And number three, we want to ensure that your experience, your clinician's experience, and your patient's experience is one to be modeled in the market.
Dr. Esteban Gershonik is Chief Information Officer for the Louisiana Department of Health and Government. And Jim Geringer is the former governor of Wyoming, Director of Policy and Public Sector Strategies at the Environmental Systems Research Institute. Gentlemen, what a pleasure having you here.
Well, thank you for having us.
And you, the two of you have actually, from Louisiana and Wyoming, across state borders, and you've actually worked together for a number of years on bringing people together. Tell me about that, if you will, Governor.
Well, we have. The State Advisory Roundtable under HIMSS is an affiliation of many state officials elected and appointed for a variety of reasons, or career people that work in the arena of public health, specialty health, health policy, advising HIMSS on how they can approach the states and understanding the state's particular challenges in dealing with healthcare issues, and then how that translates into the use of technology in a very useful and efficient way, very effective way.
And doctor, is it easier for states to do this than for the federal government?
I think from each state we've learned different lessons learned. So different states have different barriers to interoperability, data, partnerships, and so forth. So we've been able to learn from one another how we can partner, how we can have lessons learned so that we can address such issues as disaster management, opioids, and other things that affect our different states and public health.
You know, just this morning I was reading in the Wall Street Journal that something like from September of 2016 to September of 2017, the number of opioid cases increased 30%. I mean, it's mind-boggling to me that that doctors are still even prescribing opioids, and it's getting worse, not better. Where's the disconnect?
Well,
that's a toughie to address.
Well, it is. You know, if you look at the traditional ways of approaching any kind of an issue, and this turned it from a behavioral and medical issue into a epidemic. So what you usually do with a major epidemic or an outbreak, say the Zika virus or a flu epidemic, is you start to look at the precursors that will give you an indication of something happening. So that as you look at like a flu epidemic, you look for over-the-counter sales, and then you look at what's happening at clinics, and you look at what's happening with hospitalizations, and if there's deaths, you coordinate the entire spectrum of care in a community for behavioral health, for economic factors, social, not just the physical environment. You look at ways to bring all that information together so you can do some prediction about where something is going. On the flu and Zika virus, those things were assembled into an action plan. With opioids, people didn't connect all those bits of information to the point where they could have intervened at an earlier point and said why and where could we intervene. And I guess we thought we had kind of started to bend the curve down as states, and then all of a sudden it's starting to increase again.
Yeah, right. You know, it's interesting. I understand you're a chief executive, but you sound like a data scientist.
Well, I do a lot with data.
Yeah, clearly. I mean, you speak very eloquently and passionately about it. How's data driving what you're doing in Louisiana?
Well, I think we found that it's important, as we've learned in other states as well, that we need data-driven solutions to what we're doing across the state, whether it's from a flu or Zika epidemic to the opioid epidemic to disaster management when we have hurricanes hitting our shores. So it's one of those things that the same themes sort of align around all of this as to what's the data, where is it, who owns it, how do we clean it, make it accurate, how do we link different data sources around the community.
And that's a very specific process, what the two of you are outlining. I mean, this is something that applies to almost any type of healthcare or any critical issue, isn't it?
Critical issues, especially a crisis response, but what you try to do is you back up and say prevention.
Right.
The first element in any kind of community health is prevention, early intervention. Then you start to, you know, as things parse out and you have to do something, what do you do? But Esteban mentioned something very crucial to that, and that's authoritative or reliable data. How do you assure that the quality of data is there? You look at an entire spectrum like community health, but you also look at individuals. You want to have both of those happening, and for preparedness for something like he's described, how does a community work together on a routine basis? If they establish those protocols, the data exchange, the reliability, the exchanges, the interoperability, then it will work in a crisis. If they haven't done it on a routine basis, it doesn't work in a crisis.
Sure. How does Louisiana deal with that?
Well, I think what we've learned, and as we've learned from other states, I think the state advisory panel has sort of helped serve to build partnerships. So I think from a state entity, you're the one convening the partnerships around all the different components in the state, whether it's from a medical standpoint, from a social services standpoint. Again, with the opioid epidemic, it's something that crosses through state troopers, crime lab, coroner offices, behavioral health. It sort of gets the full spectrum. So as a state entity, you're able to build those partnerships and align those people at the table and work together both in the public and private sector together. So not just to have the correct data and to link it, but then down the line to do that predictive modeling so that you can be ahead of the curve and be prepared for that next issue that will come across our states.
Yeah, predictive modeling.
Thank you, yes.
Developing scenarios where you can say, if this, then what can we do?
Governor, this is exciting. I mean, you know, who would have thought 10 years ago that we would hear governmental officials talking about predictive analytics, and here you are an advocate.
Well,
I love that.
And that's the way it's going. When you look at the HIMSS call to action for how a lot of these things are unfolding, you look at the trends that are out there, some of the issues that have cropped up already here. You know, IBM has Watson. There's a big trend toward blockchain as a way for identity management or records management, the integrity of the record, the integrity of the ledger. That's one of the essential things for healthcare. Then you look at all the data that's being assembled from Internet of Things, from wearables. People are taking more responsibility for their own health, from fitness machines to anything else. How do you integrate all that data? And then how do you analyze that? So the idea of machine learning or artificial intelligence, those are the concepts that are just now starting to break on the scene that even 5 years ago people weren't talking about. And then you introduce cybersecurity, because when you assemble that much information, you have a lot of vulnerabilities.
Esteban, it sounds to me like what we're talking about here is a massive public-private partnership where everybody comes together, government agencies, hospitals, public and private, and industry, technology, et cetera? I mean, am I being grandiose?
No, I think you're right on point. I think the one thing that you discussed earlier is like, what's the federal stake in all of this? And I think the federal government has sort of helped build a framework for how each state can do this, because not only do we have to do things internally within a state, we have 64 parishes in Louisiana. So what we've done around the opioid epidemic is take a look at visualizing where we have sort of the hot spots for deaths, for prescription practices, and so forth, and target our actions around where there needs to be treatment and prevention. But the next thing that we have to do is, once we do things within our state, how do we partner with the states surrounding us so that we can see that flow across states, so we know what's going on in Texas, Arkansas, Mississippi, and be prepared so that we can sort of do things internally, but be prepared to do it around our convening states as well.
And the other issue would be, how do you pay attention to the variety of demographics that are out there and the density or lack of density of population? You look at New York City or Los Angeles, LA, but how spread out it is. I spent 5 years out there with the space program, and I'm in Wyoming, where the average density is 6 people per square mile. It's barely within eyesight of each other.
Right.
You have to figure out ways where you can provide that kind of coordinated care for a wide range of populations. They might be vulnerable populations, such as the elderly or poor that don't have access to care. And the whole issue of treatment for opioids, what's the demographic that's most likely in your community to be hooked on it? In Minnesota, it was 17-year-old girls on heroin. Up in the Northeast, I think it was predominantly black males of a certain age. It has no stereotype.
No.
So part of what you try to gather with what they've done in Louisiana is say, where is it happening, why is it happening, who is it happening to? Now how can you trace up what to do from there?
Well, Governor and Doctor, thank you for leading the charge on your committee. We appreciate it, and we certainly look forward to hearing from you.
Thanks for the opportunity.
Thank you.
Appreciate it.
Thank you. All right, Sarah London is Chief Product Officer at Optum Analytics, and I think, as I've noted before, Optum, one of our partners here at HIMSS. All right, Sarah, tell me all about Optum IQ.
Sure. So we're really excited to be highlighting Optum IQ at HIMSS this year, because in addition to talking about all of our products and services, Optum IQ is really something that is infused into everything that we do, and it is a way to talk about capabilities that we've been building over a long period of time, but we're now at a point that by bringing those together, we can take the solutions that we offer to the market to a completely different level.
In other words, the analytics that had governed payer relationships can now be applied to patient relationships.
Absolutely. And if you think about the work that we've done for the last decade to curate 100 million clinical lives, if you think about the work, think about Pandora, right? And the fact that it can offer you great musical selection based on the kinds of music
and how's
you
it
like
know
to
I like those
listen.
songs?
Because, right, and they spent a decade actually annotating and curating the data around music, and that's homework and gritty work that Optum has basically been doing for 10 years that no one else has done. And now that we've done that, and that we have done all of this work to develop analytics on that, we can actually drive to the next level, which is starting to not just be descriptive about what's happening in the system, but really be predictive and then actually be prescriptive. So if we are talking to a patient, we can say, because of everything we know about you, we see all your data. Not only here's what we think you need to do to stay healthy, but here are the recommendations we think you're most likely to follow. And so the interaction is just such a higher value interaction for the consumer.
What enabled us to go from just collecting data to analyzing data to now, as you just said, predicting what might happen in the future, predictive analytics?
So first of all, a lot of hard work and a real focus on that. But the way we think about Optum IQ is it's really 3 core components. So it is that curated data, and then using that to build analytics, but it's also the applied expertise. So we have 25,000 subject matter experts in Optum that work across the entire system and are able to bring a knowledge of how things work and how things could work better to lever the data and the analytics to actually tell a different story.
So pick a disease and walk me through how you'd approach it on these 3 different, I don't want to say silos because that implies they're walls, but 3 buckets. Diabetes, obesity, et cetera. How would you attack diseases like that across the spectrum?
Yeah, great question. So if we start with the data, so one of the things that's fascinating is if you look at the data that we collect on patients today, even an electronic medical record, which is 80% of it is non-discrete. And then above that, when you actually do the work to pull that data out and codify it, what you find is that somewhere between, for most providers, somewhere between 30 and 62% of diabetics go unrecognized in the system. Because a doctor makes a note over here, they don't actually code it, the payer doesn't know about it, they may not even have a conversation with the patient about it because they might not be talking to the patient about diabetes. And so what happens is we're able to develop algorithms that comb that data and say, this patient is actually shows all the clinical indicators of a diabetic, and we're able to serve that up to a provider to say, is this someone you should be treating in a different way? And then what happens is you go from having a patient who is unrecognized and not treated, who ends up going to the emergency department because they have a diabetic issue, they're not managing their obesity, they have depression, their utilization of the system, their patient experience is horrific, to a patient that gets proactive outreach from a provider. Someone says, we're going to hook you up with a nutritionist, we're going to get you on the right medication, we're going to talk to you about how to manage this disease. This is not some, terrible, you're going to, you're going to have like an awful experience for the rest of your life. This is something you can manage through. And from a patient perspective, it's a completely different experience. And from a system perspective, you end up driving down the cost of that patient's experience with the system, so it's a win-win.
So there are a couple of sort of follow-ups that come into my mind. Number one, if it's data dependent, that means it's patient participatory dependent. Patients need to go to the doctor and they need to have regular tests so that there is data to evaluate in the first place. Is that a new mindset?
For patients or for the system?
Well, I mean, both. I'm a terrible example. I go to the doctor when I get sick. I never do preventative stuff. How do we change me? How do we make me embrace going to the doctor and taking better care of myself?
That's a great question. And I think the neat thing about having done all the work that we've done on the data that we have is that knowledge allows you to start to pivot out to data sets that are thinner, where you can kind of infer things. So one of the big pushes around the power of OptumIQ is driving out to the consumer and saying, what are the data sets that we can collect about you that actually sit outside of healthcare, but tell us what your habits are that may actually help us predict when to bring you into the system. And so one of the things that Optum is doing within our Optum Ventures arm, which is also very tied into this idea of kind of how do we elevate data analytics and expertise in evaluating up-and-coming companies. We have a company called MindStrong that has developed a capability where just by the sort of passive interaction with your cell phone, it can tell whether you are depressed. And so,
come on, you mean like, do I bang the keys hard, or am I apathetic?
So
that's amazing.
So it allows us to actually get to a place where we not only can reach out to you, right, but we can also bring a different level of value to you, so that your interaction with the health system isn't just when you're sick, it's value that we can bring to you to keep you healthy.
All right, so this now gets to one of my follow-up questions, which is, once you have that information, or at least you think that there is a diagnosis starting to take shape, I'm depressed, or maybe I'm at risk for diabetes, how do you tell me?
Yeah.
That's a tricky one.
Yes. So that happens a couple of different ways, and a lot of it has to do with our relationships in the market, right? So we create so the products that we bring out, for example, to the provider systems, right? So being able to give them the knowledge at the point of care within their EMR, right, or a notification that this is a patient who seems to have evidence of a disease and needs an interaction, that we make them a much more powerful actor in reaching out to the patient.
The doctor. So the onus is really on the doctor.
Well, so that's one, but I think we're also getting to a point where, I mean, the fascinating revolution that I think is coming in healthcare is everything sitting around the consumer, right? And so that's where, as we think about developing the capabilities of IQ, going from the big data down to the small data, down to that one patient, how do you kind of organize the system around the patient in their normal life? So we have a number of digital capabilities that we've been developing that reach directly out to the patient and give them the ability to engage at whatever level is right for them. And so for some people, you need to have that conversation directly with a provider. For some people, they want to start getting information earlier. So Rally Health is a capability that we've built that uses the data, the analytics, the expertise on a digital platform to reach directly out to the patients and create kind of a tiered engagement strategy.
You make me want to go to my doctor. It's great stuff. Sarah, thank you. Congratulations on OptumIQ. It's an amazing product.
Yeah, thank you.
Yep. As we approach the lunch hour here at HIMSS 18, we're joined by John Sharp, Senior Manager, Personal Connected Health Alliance, which is actually part of HIMSS. So we're all in the family.
Right.
We're all in this together. So helping people change behavior with apps and devices. I get it, but I'm not sure how we do it.
Well, it's, as the psychologists say, it's complicated.
Yes, it is.
But the first point I'd make about that is it really has to be designed in a way that consumers can understand it instantly. Don't make it too complex.
Right.
And make it relevant to their needs. If they're a diabetic, help them with their blood sugars, help them control their diet. If it's just for wellness, then teach them, coach them in exercise and eating well, things like that.
Yeah, right. I'm amazed how even I have become more aware of apps. I mean, I follow my footsteps every day and the miles I walk. It's kind of fascinating to know. Before I never really cared, but I never had the access to it. What's the trigger that gets people to switch?
Well, there are a number of things. Obviously, you may have heard of insurance companies that are giving incentives now for using wearables.
Yes.
But a stronger motivation is really a doctor's recommendation. So if a doctor recommends a specific app or device and convinces the patient that this is really going to help with your condition, it may even be more powerful than the drugs they're prescribing.
The panacea effect.
Right.
Who do you think does it best? Apple?
Apple has some good features. They're not deep enough into health yet to really have a major effect. Fitbit is making a shift from just pure consumer wearables to more research and medical oriented, and other companies that are dealing with diabetes and diabetes prevention, like Omada Health, really have a nice combination of an app and personalized coaching that can really make a difference.
Love it. All right, we're bumping up against our lunch hour break, so you've got to go, I've got to go, but thank you. Great
You're
speaking
welcome.
to you, John. All right, and Blaine Newton, also with the HIMSS family, Executive Vice President of HIMSS Analytics. Thanks for coming in before we all take a quick lunch break.
Thanks for having me.
And go work the room a little bit. What is HIMSS Analytics for people who don't know?
Yeah, so we're the market research arm for HIMSS. We gather data on about 375,000 facilities in 47 countries about what technologies they're using, how they're using them, hospitals and health systems, financial picture, general demographics, and we use that to help understand where the market's going. So we apply predictive analytics to that, along with the other data coming through the HIMSS ecosystem, to really try to help the solution providers and the hospitals and health systems understand where to go next.
Has there ever been a situation where you have seen a certain disease grab a foothold somewhere, and you're able to go to a hospital association and say, we're seeing more of this than we saw in the past. You need to address this and do something. I mean, am I creating a perfect scenario that doesn't happen, or does it?
You know, so we help the organizations that find those things out. We help with the frameworks, and that prescriptive type analytics is happening at some very prestigious organizations, large organizations. It's not ubiquitous and it's not filtered down. It's the barriers to that kind of prescriptive precision medicine are pretty high still. So only the largest kind of research centers are engaged in that.
So can you give me an example of where you really are seeing it take a foothold?
Yeah, there's about 450 health systems in the US doing some really interesting things around precision medicine, genomic level precision medicine, proteomic level precision medicine, getting into prescriptive. It's mostly centered around the large academic research centers, so UT and MD Anderson, and you're seeing it at Mayo Clinic and Cleveland Clinic and UPMC. So kind of the names you'd recognize as you're walking around the floor, and really heavily focused in oncology, with cardiology, especially pediatric cardiology, accelerating very quickly.
Yeah, boy, I'll say. Interesting also that I'm not hearing you say necessarily state entities or government agencies. It's still private.
Very much so, very much private. And the private organizations are really pushing their capabilities through their networks. It's kind of a hub and spoke model, so the work is being done in a centralized facility and being pushed out to the other affiliated organizations. So very much private, very much focused on patient experience as a main driver.
If people want to know more, where can they go on the HIMSS website to find out?
So HIMSSanalytics.org, we have our own site there, and we're happy to engage and help out, whether it be through our Logic platform, market intelligence platform, or through our suite of maturity models that help governmental agencies around the world understand how to adopt and implement technology.
Great. All right. So HIMSSanalytics.com.
.org.
.org. Yep. Excuse me. That's right. It is an org.
It is an org.
It's that big.
Yeah.
In our 55th year.
Incredible.
Okay. Great. All right. Matt Fisher, partner of Merrick, O'Donnell, Damali, and Lugie. Here he is.
Hi.
Hello. How are you?
Doing well. How about you?
And what's your name?
Matt Fisher.
Oh. That's you.
Yes.
Well, imagine that. You know, every now and then they surprise me.
It's always good to be surprised.
It's always good to be surprised. All right, Matt, let's talk. Tell me what brings you to HIMSS.
So usually it's privacy and security issues. So still keeping an eye on that. Ties into my legal practice. But also keeping an eye on value-based care this time around too. Doing more of that with my clients.
Yeah, value-based care. I mean, I didn't appreciate how important it is to everyone until HIMSS began. I mean, that's really one of the big things this year.
Yeah, no, it certainly has been a focus. And I think you're actually seeing more sophisticated tools. It feels like there's more maturity to the market than I've heard in the past couple of years.
Yeah, that's right. And this notion that fee for service, it's like, we get it. That doesn't work anymore, right? And even hospitals are getting it. I had one hospital director tell me he would much rather have 200 people come in for colonoscopies than and I keep repeating this, but it's just so powerful, 200 colonoscopies rather than one person come in for cancer treatment.
Yes, no, it makes sense. And that's really the shift of focus from responding to an event as opposed to thinking ahead and being proactive and trying to keep people healthy. You want to, as you said, you want to keep people out of the hospital, so do these preventative measures and actually make money off of it, because we have to be honest, that's why, even if it's a nonprofit system, they're around to bring in money because you need money to operate.
Again, you're a lawyer, so where are the pressure points?
I guess in terms of where, because it's
there's always resistance when you go someplace new, and you try to take a system from what had been to what is to what could be.
Yeah, from that perspective, one of the pressure points is you have to hit a critical mass. Because when you're talking about value-based care, until you have a high enough number of your patients in that type of system, you're losing money off of it, because on fee-for-service, you're trying to churn through patients. And obviously that's not the goal in value-based care. In a value-based care, risk-based arrangement, the whole goal is you want to keep people out of the system. You want to keep them out of the office. You don't want them coming in, because the more services you provide, the more you're eating into your, usually a per member per month payment. So you're trying to keep as much of that defined bucket as you can. And it's also adding on other types of services like care coordination, care management, that fee-for-service doesn't compensate, but in a value-based world, maybe you have additional funds. Although, from my perspective, that's a big concern.
Yeah.
You have some government programs where you'll get additional money in the first couple of years to help bring in those new types of employees or new types of management operations. But when those funds go away, are you going to be able to sustain paying for all of them?
Yeah. Okay, Matt, I'm being totally unfair because we're bumping up against a lunchtime break, and you just jumped in here at the last minute to help us out. So thank you. I apologize for having to cut you off. But great conversation. Can we catch up in the next hour?
Sure.
Offset? Done. That's the beauty of HIMSS. You can keep the conversation going. Manish Shah is Senior Vice President and Chief Information Officer of Community Health Systems and joined us yesterday with a perspective.
The journey for me actually was to try to figure out and understand how organizations in healthcare are thinking about unlocking patient experience and how they become relevant in the care and the continuum of care for patients before, during, and after. And What I heard this morning as a kickoff from SEMA was actually refreshing that the administration shares in that value of unlocking the patient data and putting the patient data at the forefront of their care. That entire decision process will really lead to what's called the Blue Button Initiative. And I'm really looking forward to organizations that are represented here integrating the Blue Button Initiative into their products and unlocking the data that for so long has been locked up and not been really used in a valuable way that can drive better patient care. So for me, I think it's really exciting time in healthcare that we're thinking about consumerism, we're thinking about the patient first, and really HIMSS 18, for me, states that this is the beginning of that journey and a commitment by the administration that they are willing to participate in that. So I'm really excited to see what the world evolves into as healthcare transforms to consumerism and patient delivery and patients at the heart of how we do things in the future.
An amazing series of interviews today, and that's what we're trying to do here at HIMSS TV, is bring the excitement of this room. As I look around, there are hundreds of people. Okay, a lot of them are going to lunch right now, but they're going to be coming back and participating on the showroom floor. We have so many different vendors. I mean, there are 47,000 people here. It's like, I'd say a small town, but that's actually a pretty large town. It's our 55th year, and we're so glad that you're a part of it. HIMSS TV, it's our first year that we're actually doing this. We're going to be back tomorrow with probably about another 24 interviews, and if you were to just say, what do you think happened today? Well, I would tell you, here's what I learned. Public-private partnership is huge. We have the governors, former governors, I should say, from Wyoming and Vermont telling us about how they're bringing government and industry and academia together. That's exciting. Predictive analytics, where we're not just collecting data or analyzing it, we're using it to try to figure out what we can do in the future to get ahead of healthcare issues. That's exciting. And then finally, value-based medicine. It's no longer about fee-for-service, but actually trying to be preventative in the process. Telemedicine, one of the ways that we're doing that. I mean, there's so much to talk about. I could go on, and I won't. I'm going to let you take a break and have lunch. If you'd like to see any of the interviews from today, just go to our website. You can also see all of this on social, hashtag HIMSS18. I will be back with the whole team tomorrow morning again. We look forward to seeing you then, and thank you for joining us.